promises to be an exceptional meeting. There are a few things I will remind you now and several other times that you won't want to miss. One of them is the gala on Friday night. There are still tickets available, but not many. We have some interesting honorees. Barry Bittman, who is going to put on one of our most memorable Friday morning sessions. This will be a truly extraordinary, clinically, philosophically, and technologically. So don't miss Friday morning. But Barry Bittman and Diane Rehm from NPR, Diana Soviero from the Met, Terry Stewart, who's the CEO of the Rock and Roll Hall of Fame, and Bobby Rydell. And if you don't know who Bobby Rydell is, then you need more gray hair and you need to listen to some rock and roll. So consider the gala, and certainly also don't miss Friday morning. This afternoon's session is tutorial. All are welcome, but it is intended especially for people who are relatively new to the symposium and those who may not work daily in the jargon of science and medicine. We hope to lay a groundwork that will make it easier for all of us to understand the papers and the terms throughout the week. Several of us will be chatting with you this afternoon. Ron Scherer, Johan Sundberg, Rahul Shrivastav, Christy Ludlow, and I. Ron, did I forget anybody? We hope you will enjoy it. Do not hesitate to ask questions. We're here to make the voice and the symposium more interesting for you. As with any instrument, understanding the voice starts with understanding the parts that make it up. Singers and actors have been somewhat behind other musicians in this area. There is nary a violinist who doesn't know the difference between the bridge and the neck. But there are still singers running around who think the vocal folds go this way. None in this room, of course. So we'll start with a very brief overview of the anatomy of the voice and a little bit about how it works. The voice is truly extraordinary. In a moment, it can convey the terror of a scream or the beauty of a song. Surprisingly, it has only been in the last 2 or 3 decades that we have begun to really understand how all of that works, and even so, we are far from understanding all of it. The anatomy of the voice is not limited to the region between the top of the chest, or clavicle, suprasternal notch, and the hyoid or tongue bone. Virtually all body systems are involved. If you look at any singer, pop or classical, closely, you can see that. The singers know that. We, scientists and physicians, took longer to figure it out. That's Springsteen, for those of you in the room who knew right away who Bobby Rydell was. The anatomy of the voice is not limited to that region, but includes virtually all body systems. Nevertheless, we are particularly interested in the larynx. We should remember, however, that it is not necessary at all for intelligible phonation. Laryngectomy patients communicate perfectly well. It is, however, necessary for normal or superior phonation. As we look at people as patients or clients for speech-language pathologists or singing or acting teachers, or as scientists look at how voice is produced or functions or fails to function, we try to break down and analyze parts where problems might lie or parts that improve and develop as voices are educated. One of those important areas is the larynx. For convenience, we can divide the larynx into skeleton, mucosa, intrinsic muscles, and extrinsic muscles. Any one of these may be responsible for a voice problem in the doctor's office or in the studio. And understanding this anatomy helps us give us a vocabulary through which we can more articulately analyze the problems we hear, as much as singing teachers, as physicians. The laryngeal skeleton is composed of several cartilages, the thyroid and cricoid cartilage and the paired arytenoid cartilages. There are other structures of less importance. The thyroid cartilage has a prominence, especially in men, called the Adam's apple or thyroid prominence. It is a C-shaped structure, not closed in the back, that sits in the neck above the cricoid cartilage, on which are perched the paired arytenoid cartilages. Above them is the hyoid bone, and behind them is the spinal column with a small intervening amount of soft tissue. At birth, the laryngeal complex is high at around C3. As we age, it drops down to around C7. That lengthening of the vocal tract is part of what we perceive as vocal aging. Dr. Sundberg will explain the acoustics more to you later. The cricoid cartilage is circumferential. It's the only completely circumferential structure in cartilaginous or bony structure in the airway. I told you that the spinal column is behind the larynx, so you can imagine that if the larynx is struck from the front, that little intervening cushion of tissue does not provide great protection from impact against the bony spinal column wall. When we are born, these structures that we think of as laryngeal cartilages are indeed cartilage. As we age, they ossify and turn to bone, starting in our teens or 20s, and by the time we reach our 60s, they are largely ossified. So if we're struck in the neck by a steering wheel or an elbow, and elbows happen not only on the hockey field and basketball court, but also on the opera and musical comedy stage. When we're young, these cartilages tend to collapse and spring back. As we get older and they're ossified, they're brittle and they fracture. Are there any otolaryngologists in the room? Good, a few. Glad to have you. That distinction, the age distinction, also determines the suitability of various surgical procedures. For example, if you are doing a gender modification, male to female, and wish to do a cricothyroid approximation, as a Shiki would do, or cricothyroid subluxation, as we described, for a patient in his or her 30s, it's very relatively easy to compress the cricoid cartilage and arch and bring them underneath the thyroid cartilage. For a transgender patient in her 50s or 60s, it's virtually impossible, and that's not such a good approach. This is anterior, posterior. Here's the thyroid prominence or Adam's apple, so we know this is a drawing of a male larynx. If we split the larynx down the middle, still anterior or front, posterior or back, here's the thyroid cartilage. Here's the front and back of the cricoid cartilage. There's no back of the thyroid cartilage because it's C-shaped and it doesn't have a back. Here is the arytenoid atop the cricoid cartilage, and extending from it is this white structure incorrectly labeled vocal cord. Vocal cord is a term that we pretty much abandoned more than 20 years ago. It's not very descriptive. You will see why. We use in English vocal fold. The German term vocal lips is probably most descriptive of all. However, this white structure, which I ask you to remember for reference, is neither the vocal fold nor the vocal cord. It's mislabeled altogether. The laryngeal cartilages are connected by joints, the cricothyroid joint and the cricoarytenoid joint. For the singers who may not have had pedagogy courses, the anatomy of the larynx is remarkably easy to remember. If you can remember cricoid, thyroid, and arytenoid, you have almost all of it. Anatomists are remarkably unimaginative. Everything will relate to these basic skeletal structures. These joints are not screw-like joints. They are complex, and especially in the case of the cricoarytenoid joint, complicated shaped synovial joints. They're made of the same materials as elbows and knees and are subject to the same afflictions. They can be dislocated or subluxed. They can become infected. They can get arthritis and stiffen, and when they do, the ability of the laryngeal cartilages to move with relation to each other is impaired. This is a larynx looking straight at you. This is the front. Here's the Adam's apple or thyroid prominence again. Once again, the thyroid cartilage, the cricoid cartilage, and the hyoid bone or tongue bone. There is a membrane between the thyroid cartilage and the cricoid cartilage, cleverly called the cricothyroid membrane. And there is another membrane between the thyroid cartilage and the hyoid bone, cleverly called the thyrohyoid membrane. Correct. Picture in your mind's eye where the vocal folds are. You can't see them, but when you look at a person in your office, in your speech pathology office, in your singing studio or your acting studio, your X-ray vision should allow you to picture holographically what's going on inside. So think, where do you think the vocal folds attach? Here, here, here? Where are they? Which way are they running? What is it that you're working on? Well, as we start to take away things, here you see absence of the thyrohyoid membrane. Inside you see this leaf-like structure, which is called the epiglottis. It keeps your Chianti out of your lungs. As you remove the cricothyroid membrane, and this space is opened a little artificially, you see the signet ring-shaped cricoid cartilage, and perched atop the pyramidal-shaped arytenoid cartilages, which have an apex, a vocal process, and a muscular process. There are muscles that attach to the muscular process. That white thing, mislabeled vocal cord, you will see in a while, attaches to the vocal process. For the physicians in the room, I won't talk about this much, but will let you know that there is literature available on the diameter of the trachea and various parts of the airway. And in some cases, it is smaller than the endotracheal tubes that our anesthesia colleagues like to insert. It is worth knowing and having readily available this information as we try to encourage our friends at the head of the table not to make more cases for us, especially on our own patients. This is the larynx again, an anesthesiologist's eye view. You're at the head of the table. The person's feet are away from you through the screen, so this is front, back, right, left. Hyoid bone, thyroid cartilage, epiglottis, arytenoid cartilages, and emanating from the vocal process, this white structure, again, incorrectly labeled vocal cord on that earlier drawing, attaching more or less near the midpoint of the vertical height of the thyroid cartilage. For the otolaryngologists in the room, I will remind you, although I'm sure you all remember well, that the vocal process Dan, fortunately, I travel with my own, but this is fighting back a little bit. I don't know if it's batteries or the button. The vocal process of the arytenoid is of embryologic different origin from the rest of the arytenoid cartilage. So there is, Dan, I give up. Ron, this is the one you hate. So there is an embryologic fusion plane right here where the vocal process joins the body. It is a fracture, or in fact, an avulsion waiting to happen. That is why we never put an instrument below the vocal process and lift. There is an altogether different technique for reducing anterior arytenoid dislocations. The arytenoid cartilage moves in complex planes. It used to be said that it rocks, glides, and rotates. It revolves in a more complex fashion than that because the joint facet is on the curved portion of the cricoid cartilage. So it is elliptoid, torqued a little, and as the arytenoid cartilage moves out or in on the cricoid cartilage, it changes not only angulation, but also height and relative position, axis, with relation to the cricoid cartilage. So it is very complex motion that we are not capable of restoring very well. This is a CT scan, one of Jean Abitbal's. These are the arytenoid cartilages in adduction, and you can see a nice little joint space. It looks like a little miniature temporomandibular joint. And here they are in entirely different position, in an entirely different location, in normal abduction during inspiration. The motion is complex and interesting, and the degree of attachment is less than many people think. As you look at these joints from slightly different angles, and especially from this angle, you can see that the points of attachment are smaller than most of us think they are. These are surprisingly fragile joints, and it is unexpected that they don't get injured more often than they actually do. I remind the doctors in the room, this is not a reconstruction, it's not a model. These are CT scans from humans. It uses software technology that was developed by Jean Abitbal and Albert Castro in Paris, and all of their CT scans of the larynx are processed and look like this and look a lot better. There are a lot more views. Unfortunately, we're not doing this, and they've been doing it for more than a decade. We're not doing this as well as we should most places in this country. The intrinsic muscles are responsible for adduction, adding, like bringing together, abduction, ABD, pulling apart, and longitudinal tension. So they move the vocal folds. In order to do that, they need to be told to do that. They're told by the brain, which is rooted through nerves, which Dr. Ludlow will tell you all about in a little while. For those of you in the room who don't know this anatomy, but who may someday have to take a multiple choice test, this is as easy as everything else. You need to remember one nerve and two muscles. The superior laryngeal nerve innervates the cricothyroid muscle. I'll tell you now that the cricothyroid muscle controls longitudinal tension and lets you change pitch. That's one nerve that goes to one muscle. You also need to remember the posterior cricoarytenoid muscle. We'll come to that later. But if you can remember that the superior laryngeal nerve innervates the cricothyroid muscle, then everything else is innervated by the recurrent laryngeal nerve, and you can just check the right boxes and you'll be fine for the rest of your life. The abductor is the other muscle you have to remember. That's the posterior cricoarytenoid. So the cricothyroid lets you sing higher, and the posterior cricoarytenoid lets you breathe. It abducts. It pulls your vocal folds apart. All the other muscles are adductors. They are intended to keep you from having things go down the wrong pipe and choking to death. And as an incidental benefit, they also allow you to speak and to sing. So the thyroarytenoid, lateral cricoarytenoid, interarytenoid, you'll notice they're all named after the cartilages to which they attach. So we won't go over all of this in great detail, but you need to know. In the 1970s, when I was a resident in Ann Arbor, we needed to know this stuff long enough to pass boards, and that was it. No longer true. We do laryngeal electromyography on a daily basis. We provide our speech pathologists and singing and acting voice specialists with relatively quantitative information on which nerve muscle complexes are weakened. If there is a 30% reduced recruitment in the right cricothyroid muscle, superior laryngeal nerve distribution, the therapy program is targeted to bringing that muscle back up into strength and balance and to preventing compensatory hyperfunction in the other muscles. The same is true with all of those muscles. So we really use this information. Nevertheless, I will make this brief. The posterior cricoarytenoid muscle goes from the back or posterior aspect of the cricoid to the muscular process of the arytenoid, and as the muscle contracts and shortens, it pulls the muscular process back, thereby swinging the vocal process out and up a little bit. This raises the observation that these muscles do more than adduction, abduction, and longitudinal tension. Also, they alter the shape and position of the vibratory margin of the vocal fold. The posterior cricoarytenoid, as I've just showed you, lifts and tightens a little bit. The cricothyroid, which is innervated by, thank you, those of you who are still awake out there. Yes, the superior laryngeal nerve raises pitch, so it increases longitudinal tension, so what would you expect? This dotted line is neutral position. As you stretch the vocal fold, it sharpens, the edge narrows a little bit. I haven't talked to you about the vocalis or thyroarytenoid medial belly yet, but I will tell you that it sits more or less where that white structure, mislabeled vocal cord, was. So what do you think happens when it fires? What moves? Nothing. It's between two immovable places, so it's isometric. So what happens? It bulks up. It forms the body of the vocal fold and is responsible in part for lateral resistance. That is one of the reasons why when we treat somebody with spasmodic dysphonia with botulinum toxin, we get fluency, but we almost never get normal voice. For speakers, fine. For serious high-performance singers, not so fine. As they get loud, lacking the lateral resistance because of weakness of this muscle and its inability to become firm and bulk up like this, as one vocal fold hits the other vocal fold, the vocal folds get knocked out of the way. And that's why we have, one of the reasons, we have some vocal instability. Vocalis muscle, medial belly of the thyroarytenoid, going from the arytenoid to the inside of the thyroid cartilage. I will mention just for the physicians very briefly that in 2004, one of my residents and I published what to me was astonishingly the first paper describing the gross anatomy of the thyroarytenoid branch of the recurrent nerve. I came across this because as I was writing the third edition of my professional voice book, I spent about 6 months rewriting the anatomy chapter, and I looked everywhere for the anatomy of this nerve. Because I had done operations in this area, thyroarytenoid nerve sections for spasmodic dysphonia, and sometimes had trouble finding it. I assumed that somebody in the 19th century would have gotten a master's degree describing the gross anatomy of all of the cranial nerves. Everything, Gray's, Pernkopf, the old German literature, the Russian literature, everything I could find said, and the recurrent nerve divides into the following terminal branches. And nothing described the variations of the terminal branches. And we're talking 21st century. So there is a ton of stuff that we don't know, even as basic as the gross anatomy of one of the cranial nerves, that's still left for those of you here to investigate and research. And it turns out, you can look that article up if you're doing a TA neurectomy, it turns out there's considerable variation in the position of the nerve and in the number of branches of the nerve. It explains probably some clinical failures in doing that operation. The lateral cricoarytenoid muscle brings the vocal processes to the midline. It works ordinarily in concert with the interarytenoid muscle so that there's relatively broad closure. Those of us who've been around for a while have seen patients with intractably recurrent laryngeal granulomas at the area of the vocal process, even after good voice therapy and good reflux control and steroid injections and multiple surgical excisions. If you look closely in a frame-by-frame analysis or high-speed, you will often see that in those patients, they have a lateral cricoarytenoid dominant closing strategy. So they have a forceful point contact at the vocal process, and then the interarytenoid becomes involved and they close more broadly. So the treatment for that is botulinum toxin injection into the lateral cricoarytenoid muscle in low doses and voice therapy. In our experience, at least, it's very hard to break that pattern with voice therapy alone. It's easy to break it with botulinum toxin followed by voice therapy, and to the best of my recollection, we haven't seen recurrences. In many cases, when you do that, the granulomas will resolve without even having to excise them again. But it's a discoordination of the way the muscles are used, and it is remediable. The interarytenoid muscle, as Dr. Ludlow may tell you, is the only muscle that really seems to have bilateral innervation. But I should mention to you that almost everything that we're telling you, and Christy, are you going to cover sensory innervation too? Most of what I am telling you, at least, is not strictly true. There is crossover from nerves to other places that we don't usually tell you they are. There's some very interesting things that happen along the vibratory margin, particularly things described by Ira Sanders that show differential innervation of the top and bottom portions of the contact edge of the vocal fold, which doesn't seem to make sense with what we know about myoelastic aerodynamic function. You're getting the introductory simplified version. The more you learn, the more interesting it becomes. The cricothyroid muscle allows you to sing high notes by bringing the cricoid and thyroid cartilages closer together. As they come closer together, the cricoid rocks back on the cricothyroid joint. So the arytenoid gets further and further away from its attachment in the thyroid cartilage and is therefore stretched. And we'll talk about how that lets you get high notes in a while. Now, the laryngeal cartilages, as I told you, are not attached by screws, but by joints that have some play. So as you accordion the larynx together or pull it apart, the angles among the laryngeal cartilages and the resting lengths of the intrinsic muscles change, so they're a little different. Those kinds of motions are affected by the way the larynx moves vertically up and down in the neck, and that is controlled by the strap muscles, the muscles in the neck, those things that you see standing out on weightlifters or your average mediocre Helden tenor. Those muscles attach directly to the vocal folds and need to, in classical Western singers, maintain the larynx at a relatively constant position throughout a pitch range. That's necessary because in classical Western music, we value uniformity of quality throughout a pitch range. It is not true because that's the only healthy way to sing. That is not so at all. There are Persian and African and Turkish and Asian singers with totally different singing styles who use their larynges in totally different ways. So do rock singers. But they can have their voices break and sing falsetto, and it's a perfectly acceptable sound. They also use microphones and are not trying to fill a 2,000-seat house with their voices alone. So it is important for us to remember, as we're analyzing the way a voice is used, we need to take into account the user's intent and needs, because many of the things that we like to think of as absolutes are not absolutes, certainly not absolute requirements for vocal health. Anterior, posterior, these are the true vocal folds in the general neighborhood of where that mislabeled vocal cord was. The false vocal folds, a little envelope in between called the ventricle of Morgagni. This is the angle you've seen before with the person sliced open this way. This is a coronal view, so the person was egg sliced this way from front to back. And you are looking at the trachea, the true vocal fold and the vocalis, or medial belly of the thyroarytenoid muscle, the false vocal fold, and the ventricle. Note particularly two things. One, the fairly large contact area of the vocal folds. You're used to looking at two-dimensional pictures and strobes. These are not like two pieces of paper. They're like two fingers that come together. There's a broad contact surface when we speak or sing. And notice the steeple-shaped convergence. This convergence, I throw this out to those who will follow me to maybe talk about more and maybe to do even more research than has been done to see whether I'm entirely making up this next statement, which I've been doing with great success for a few decades now. The otolaryngologists in the room who do thyroplasties and the speech-language pathologists who have to help rehabilitate our thyroplasties know that there are some times when glottic closure looks very good and people still either don't sound good or are working too hard. I am convinced, on the basis of no evidence whatsoever, on which I've built a wonderful career, that one of the reasons for that, and I think this is especially true with Gore-Tex, which I use a lot, is that when we do thyroplasty surgery, we're particularly careful not to put implants in too high for reasons that are known to all the surgeons in the room. If we put an implant in that's too low, or if one of the ribbons of Gore-Tex shifts and changes this convergent shape and squares this off, I believe that the change in the aerodynamics of this system is disproportionately disturbing. I believe it's analogous to the nasal valve. And I have had too many of my own patients who've had this problem, some of whom I've taken back to the operating room and fixed. But I think that we have underappreciated the importance of having medialization too low and altering the design of this. I think it has a profound effect on aerodynamic efficiency. Anybody who knows more than I at the front table find that objectionable? We do need to study it more. I'm quite sure it's causing some of the problems we see clinically. The vocal folds are divided conveniently into two portions, a musculomembranous portion and a cartilaginous portion. At birth, they're more or less 50-50. In adulthood, It's more or less 3/5 muscular membranous and 2/5 cartilaginous. The important reminder at this portion of the talk is for the surgeons in the room. We were trained that the muscular membranous portion is phonatory and the cartilaginous portion respiratory. We don't know enough to believe that. Again, those of us who've been around for a while have seen people with webs, that is scarring together of the muscular membranous portion of the vocal folds, that take them totally out of the vibratory function. And yet some of those people have remarkably normal voices using the mucosa overlying the cartilaginous portion as a primary oscillator. The fundamental frequency may be a little high, but there is certainly clarity. So we know that under abnormal circumstances, this mucosa posteriorly can function very well for phonatory reasons. I suspect, again on the basis of no evidence whatsoever, that in high-performance voice use, perhaps operatic singing, for example, that there may well be some important function to the mucosa back here that we don't yet understand. Until we know for sure one way or the other, clinically we need to treat this with the same respect with which we treat the rest of the vocal fold, and not do what we were all trained to do, which is, if there is a granuloma or some other lesion back there, just go in with a laser and burn it all out because it doesn't matter, because that's not where the voice is. I personally believe that we do not know enough to operate that way. And until people like the scientists from whom you'll be hearing later tell us for sure that, yes, that's the function, or no, it really doesn't have to do with anything, we need to preserve it and treat it gingerly. The vocal folds are covered with mucosa. They allow the vocal folds to come together and pull apart smoothly and without difficulty. There is lubrication. It is made by cells. There are a combination of glands that produce either serous, thin, or viscous, thick secretions. We balance out the viscosity under ordinary circumstances. There are some things that alter the viscosity, including things that we talk about as drying the vocal folds, like antihistamines. They don't necessarily dehydrate the vocal folds, but they may shift from a serous to mucinous predominance, which is like thickening the oil in your car engine, and it doesn't work very well. So as we are thinking about issues of vocal fold lubrication, we need to think about both hydration itself, which among other things helps shift to a serous appropriate balance, and viscosity, which can be affected by things other than just how hydrated the body is at the time. Most of the respiratory tract is lined by ciliated columnar epithelium. That means it's got like little hair cells on it. If we banged hair cells together 200 times a second as we spoke, they wouldn't survive very long. So the epithelium of the vocal folds is specialized. It's stratified squamous epithelium to tolerate the repeated contact that goes along with phonation. The edge of the vocal fold is not simply wet stuff applied to muscle as we get on the inside of the cheek, for example. It is a complex layered structure that we didn't understand until way later than we should have. This slide came from our friend Minoru Hirano in Kurume, Japan. He first published it in Japan in 1975 and in English in 1977, and this slide is the keystone of modern voice surgery and of the way we think about voice pathology. This is the glottis, or the space between the vocal folds. This is a vocal fold, the contact edge of the vocal fold. The glottis, by the way, is the one place I like to imagine anatomists found one anatomist with a sense of humor. The glottis is the reference point for the vocal fold. Everything is glottic. at the vocal fold level, supraglottic above the vocal folds, or subglottic below the vocal folds, but there is no glottis. It's non-existent. It's a space. When you say E and your vocal folds are in contact, there is no space. So I like to think that one anatomist at one time in history had a chuckle over that, but it's probably wishful thinking. The vocal fold is a layered structure. It has an epithelium, superficial, intermediate, and deep layers of lamina propria and muscle. The muscle you have already met. That is the medial belly of the thyroarytenoid muscle, or vocalis. It forms the body of the vocal fold, provides stability and lateral resistance, among other things. The epithelium and a superficial layer of lamina propria, also called Reinke's space, form the mucosal wave and shear across the vocal fold. The intermediate and deep layers of lamina propria together are called the vocal ligament, and they are your old friend, that mislabeled white structure that was called vocal cord. That's the vocal ligament around which the vocal fold is built. So we've thought of anatomy in layers. We've thought of function in layers, the mucosal wave, the body, a transition layer. Fibroblasts and other cells that are responsible for making vocal fold scar, which obliterates this elegant structure, are scarce in the epithelium and the superficial layer, but the vocal ligament and muscle are rich in fibroblasts. So knowing that, we would like to not disturb fibroblast-bearing layers and provoke scar proliferation. We have also learned to think of pathology in layers, nodules, cysts. Most other benign pathology involves either the epithelium or the superficial portion of the lamina propria. Therefore, we developed delicate surgical instruments providing sufficient precision under microscopic magnification to allow resection of the involved pathology without disturbing subjacent layers. All of that evolved from Hirano's anatomic description, and it is the essence of modern voice care. So how many of you lie awake at night wondering how the epithelium is attached to the superficial lamina propria? Well, other than Ron Scherer and I, it turns out there's a basement membrane. Are there any residents in the room? Too bad. It's humbling to know that the basement membrane was discovered and described by Steve Gray when he was still at Iowa as one of his resident research projects. And it did a lot to change the way we think about things. The basement membrane gives off type 7 collagen loops that come back up and reinsert into the basement membrane, through which pass type 3 collagen fibers from the superficial layer, and these linkages are what stop your vocal fold mucosa from flying off when you talk. Unless, of course, you have dermolysis bullosa et dystrophica, in which case they're not there, and that's exactly what happens. That can afflict other areas of the body, but it can also afflict the vocal folds. This area, the basement membrane region, contains mucopolysaccharides and lots of other proteins and other structures that are responsible for wound healing. And there is a great deal that we are trying to learn about how to influence wound healing. Also, how to predict which people will heal well. These structures differ from person to person. They are probably genetically controlled. So are some of the other components, extracellular matrix proteins that we discussed. Why should we care? Well, I'll give you one reason. How many speech-language pathologists in the room? Think about this. You have a kid come into your office referred with vocal nodules. The kid screams, the mother screams, the aunt screams. You sit there and say, everybody's screaming. No wonder the kid has vocal nodules. You treat the kid, you try to treat the mother, you try to treat the aunt. right? We were all taught that way. You're in Philadelphia. Philadelphia has, you're going to love this, Masi. Philadelphia has 500,000 Italians. Many of them live in South Philadelphia. You can stand in the middle of a street in South Philadelphia in the summertime at dinner and listen to all the conversations for six blocks in any direction. How come only one family gets nodules? There is much more here that we do not understand. And probably it has to do with this region of the vocal fold. And when we do understand the genetics of it and the chemistry and function of it, we will probably be able to not just say, well, I'm going to do this operation on you and one or two people get a big ugly scar and are hoarse forever. We may be able to do a genetic test and say your risk isn't 1%, it's 50%. And we may be able to do something to intervene, whether it's stem cells or some other genetic modification, to alter and improve the efficiency of wound healing. This kind of anatomy and study and what you will hear scientists presenting this week is not esoteric. And if you think it's esoteric now and you develop a vocal fold lesion personally and need an operation, it will become very practical to you. So, we've talked about the cover, the epithelium and superficial layer, and the body and everything moving. They are the oscillator of the vocal tract. They make a noise. The noise passes through the generator, which we'll talk more about in a moment. And in order for any of that to happen, you have to generate something that allows the vocal folds to come together and pull apart. The power comes from large musculature below the level of the vocal folds. Oscillator, resonator, power source. Now, the singers and singing teachers in the room and most of the speech pathologists understand perfectly well that if you don't use the big body power muscles appropriately, something else will try to do the work that's not designed to do the work. So let's take a quick look at how things are supposed to happen. Everything we've talked about and thousands of other things all work together in concert. Dr. Ludlow is brilliant at neurolaryngology, as you will find out shortly. It is our newest field. We could talk about it for a long time, but just think about this. When you want to say something or sing something, you draw, probably on both sides of your brain, you draw on auditory memory and develop a concept of the utterance you plan to make. You pre-tune everything in the vocal tract and perhaps elsewhere. You generate a sound to target, and within milliseconds, you adjust it to target by audition, by auditory feedback. And if you are a singer, and you're in a choir or in front of an orchestra, and you're deprived of auditory feedback, you do it by tactile feedback, singing by feel rather than by ear. A remarkable, complex neurological accomplishment about which Dr. Ludlow will tell you more. Let's talk a very little bit about breathing because you will hear more about that too. Just an introduction. Breathing is a combination of active and passive forces. You are actively taking in a breath. You are then relaxing, and the air comes out of your lungs to some extent. I, on the other hand, am up here pontificating, using muscles of expiration to drive the air out, and the muscles that I recruit to do that, combined with the airflow and everything else, we call support. The diaphragm is primarily a muscle of inspiration. You use it to take a breath in, although singers talk about using their diaphragm all the time. So the diaphragm and the external intercostal muscles bring in air, right? That's not strictly true either. Nice work by von Euler and Lee Anderson and Johan Sundberg A long time ago, doing EMG studies showed that elite singers use the diaphragm during singing, during expiration, as part of the fine-tuning mechanism for high pressures. So even that basic, is the diaphragm primarily an inspiratory muscle? Yes. Exclusively? Apparently not. The other muscles in the abdomen and chest and back are expiratory muscles. So what do? Suppose you have a balloon full of air and you want to squish the air out of the top of the balloon, or you want the air to go out of the top of the balloon. What do? You squeeze the balloon a little bit, right? Physics, I'm sorry to say. You have a fixed volume of gas in a container. You make the container smaller, the pressure in the gas goes up. That's what you're doing. We do that with a little more complexity than just that. But that's basically what it's all about. As you tighten your gut muscles and pull your sternum down and tighten your back muscles, you're squishing gut contents up against the diaphragm and into the thorax and pulling the sternum down and making the cavity smaller so the gas in your chest cavity has higher pressure, and then you learn how to direct it as subglottal force. So let's do a brief review of a phonatory cycle, starting arbitrarily with the vocal folds closed. You close the vocal folds with an elective amount of adductory force. You choose how hard you want to hold them together. You then breathe, use your support, generate expiratory pressure against the bottom of the vocal folds. And when that subglottal pressure is greater than the adductory force with which you've chosen to bring your vocal folds together, you blow them apart from the bottom up and from the back forward. Air then flows, and because of the elasticity of the tissues and the Bernoulli principle, that's the one that sucks you toward a passing truck at high speed, the vocal folds start to close, again from the bottom up. Note that we are talking about differential motion of that little contact edge of the vocal fold. It's called a vertical phase difference, and it is very important to normal efficient phonation. When we do surgery to repair scar and try to get vocal folds vibrating again, and you'll hear a paper on that this week, we are careful to use whatever material we use to replace, not just on the surface of the vocal fold, but over the full vertical distance that needs to vibrate. Moreover, in a high soprano, you may go from closed with high subglottal pressure to open with not zero, but much lower subglottal pressure, to closed again 1,200 or 1,400 times a second. We have no muscle systems with refractory times anywhere close to that. So this is not muscle action. This is an aerodynamic phenomenon about which you will hear more from those people who speak after I do. So let's talk about a couple of basic characteristics of the sound and how we create them. One of them is frequency. How many times do the vocal folds open and close in a second? It corresponds to what we perceive as pitch. They're similar, but not the same. The vocal folds behave differently under normal circumstances at different frequencies. In normal voice, modal voice, regular speaking, as I'm doing now, for example, they're closed about half of the time and open about half of the time. In vocal fry, that kind of sound, they're closed most of the time and open in little bursts. In falsetto, they don't come together at all. So if we do stroboscopy on everybody the same way we do mirror laryngoscopy, pulling our patients' tongues out and having them say a falsetto, ee, so we can see their vocal folds, everybody will have failure of glottic closure. That is why we routinely examine people at different frequencies and at different intensities. Different intensities also have normal different effects on glottic closure. Dr. Sundberg will talk with you at considerable length about what he wants you to know about the acoustics of sound. I will tell you once what he is going to tell you in small part, and then he'll tell you again. This is all his brilliance that we know this, but it is critical to us. The vocal folds produce a sound. It is much like the sound of a trumpet mouthpiece without a trumpet attached. That sort of sound. Whether you're René Fleming or Pavarotti or one of us mortals, the vocal folds themselves don't sound so great. They produce a voice source signal that drops off at, Dr. Sundberg tells us, about 12 dB per octave, more or less. And they're boring. When you pass them through our resonator, which is an infinitely variable system of interconnected resonators involving the pharynx and the mouth and perhaps the nose, what comes out isn't nearly so boring. It looks like a nice Pocono mountain range. Each of the peaks in that mountain range is called a formant, and Dr. Sundberg will tell you all about formants. They unfortunately have to do with both audibility and vowel intelligibility, which is sometimes problematic, especially if you are a soprano. Dr. Sundberg taught us about the singer's formant, and there is also something called a speaker's formant. We hear that as ring, but it is important not just to singers. Were this microphone to fail, even though I am not entirely healthy at the moment, as you've heard from the occasional coughing, I believe you can still hear me in the back of the room. Jen, can you hear me back there? And despite these miserable acoustic walls, there's a little bit of a bounce. That's called a ring. If we have that ring, it's one of the things that we use to be heard. If we don't have that ring, we have to work harder to be heard. And we will talk about that. Johan, you're going to talk about singer's formant? Good. I won't. So let's talk about how we control some of these things in the most basic sense, and then why anybody cares. I'm sure that I did that, but not on purpose. Let's talk about two of the most basic things. How do we control fundamental frequency and intensity? So let's talk about fundamental frequency. Suppose you're singing ah, and you want to sing it an octave higher. How do you do that? Well, you increase longitudinal tension using what nerve? How quickly they forget. And what muscle? Right, superior laryngeal nerve and cricothyroid muscle, and you fire them and you bring them closer together and they stretch, and so what? You have subglottal pressure, which hasn't been affected very much by that little distance, but you have made a significant increase in the length of the vocal fold. So it's acting over a larger area, so it opens the vocal fold more efficiently. It's stretched. So the mechanical characteristics of the system have changed a little bit, not quite like a stretched rubber band, but it's not too bad an analogy. So because it's acting over a large area, it opens more quickly. Because it's stretched, it closes more quickly, so it happens more times in a second. And your frequency goes up and your pitch goes up. Is that the only way to control pitch? No, it isn't. You know that. If you turn on a water faucet and then open it more widely, what do you hear? As you increase the flow, the pitch goes up too. That is not particularly efficient for us to do under normal circumstances, but it works under abnormal circumstances. If you have a cricoid and a thyroid that are mechanically fused, either accidentally or surgically, so that there is no cricothyroid action whatsoever, patients still maintain a range of about an octave with no cricothyroid muscle function ability at all. So that alternative may have relevance under some other circumstances. How about intensity? How do you control that? Suppose you attend a wonderful series of lectures on how the voice works, and at the end you wish to applaud riotously. Do you do this? No. You put your hands far apart and snap them together. So too with your vocal folds when you wish to speak or sing more loudly. You increase your adductory force, you increase the subglottal pressure to work against it. When the vocal folds finally get blown apart, they get blown far apart. There's brisk airflow, and the vocal folds snap together briskly and suddenly cut off the airflow. And that is the mechanism in which we do use airflow and control intensity. Short version. So, I asked you before, why do we care? Every day in our voice patients, we assess this kind of information, analyze it, and measure much of it in a voice laboratory. We use it for diagnostic purposes and, in some cases, for outcomes purposes. Are you going to talk about flow phonation and press phonation? And you're not. Or the acoustic advantage to going from press to flow? I shall. Thank you. Breathy phonation, which we can measure, is very inefficient. You all know what that sounds like. That sounds like somebody with a vocal fold paralysis. You are also familiar with pressed phonation. Pressed phonation is the sound of a baritone, announcing to the world that he is indeed a baritone every time he opens his mouth. It is not very efficient. Flow phonation is appropriate balance of subglottal forces or subglottal pressures and adductory forces. How much difference does that make? Well, Dr. Sundberg, again, has shown us that as you go from pressed phonation to flow phonation, you can pick up as much as 32 decibels at the sound source. Correct, Johan? What did you remember? Was it 16 decibels? You're right, it was 16 decibels. You'll see where that mistake came in a second. You're right, it's 16 decibels. I'll get you a copy of your paper. It was 16 decibels. So you're in a paper factory, and somebody has a machine putting out 90 decibels. And you turn on a second machine that puts out 90 decibels. How much noise do you have? It's not 180. It's 93. You turn on two more. You now have your hands over your ears and you're looking for earmuffs. It's 96. How many do you have to turn on to get a 16 decibel increase? 32. These are logarithms. We talked about the singer's formant or speaker's formant permitting audibility, and we've now just talked about appropriate balance of subglottal pressures and adductory forces, providing audibility by increased volume for vocal fold efficiency. Our patients almost always get in trouble trying to be heard. If we think of it that simplistically and figure out what they are doing strategically wrong, then these analyses become critical. If they are using the power source for power, great. If they're not, they're going to use delicate neck muscles not designed for power functions and they'll break down. If they're using pressed phonation and they can't be heard, they're going to work harder, increase adductory and shearing forces, and get injured. So we are attempting in all of our instrumentation and all of our analyses to figure out what they're doing, which they did first, because they generally do all of it in the process of compensation, and to identify and fix the underlying pattern. We can measure most of it. We can measure vibration, acoustic signals. We can do inverse filtering. We can do laryngeal electromyography. We can do a lot of things that gather information that is clinically useful, and much of which the following speakers will talk to you about. But the bottom line is what we can do that we couldn't do before is use more than our ears and our artistry, which we still use. We can do a systems analysis of the oscillator and the resonator and the power source and their interactions. Combine it with what we hear and what we see, and use a rational, planned, prescribed program to diagnose and to restore voice function. That is thanks to the integration of clinicians with scientists, with voice therapists, with teachers, much of which started at this meeting 40 years ago, thanks to Jim Gould and a few other far-sighted people. With that, I give you the extraordinary Dr. Christy Ludlow, who will teach you all there is to know about the nervous system and the voice.
That's a bit of an act to follow. Sorry. Could I have my slides up, please? Okay, I'm going to be discussing the central nervous system control of the larynx for voice and speech. I'm going to be focusing on the thing in the top there, the brain, and how that interacts with voice and speech and what we currently understand about that. Unfortunately, we don't have very complete knowledge about this system. But I'm going to review neurons, neurotransmission, that is how neurons communicate, motor neurons and sensory neurons, and interneurons, which are the majority of the neurons in the central nervous system. The brainstem, the basal ganglia, the white matter tracts between different regions of the brain, and cortical control. So let me start with the neuron. We have a cell body and dendrites and cytoplasm and an axon. And the axon is important for sending a message through by an action potential from one neuron to a muscle or to another neuron. Motor neurons are in the spinal cord and the brainstem and connect through axons to the muscles. Sensory neurons are in the ganglia just outside the central nervous system and communicate into the spinal cord or the brainstem. But the majority of the central nervous system is made up of interneurons that communicate either through excitatory or inhibitory neurotransmitters. An example of an excitatory one is glutamate, and an inhibitory one is GABA. And GABA is used a lot in the central nervous system, the cortex in particular, which we call the great inhibitor. Now, neurotransmission is from one neuron to another. Here schematically shows a neuron going through an axon down to another synaptic bouton on another neuron, and there neurotransmitter is released to induce a response in the second neuron. And so we have excitation of one neuron through an axon going through an action potential to a synapse to release a neurotransmitter at the synapse and fire the postsynaptic neuron. So this is a pretty simple process. However, it's highly complex in that it involves many neurochemicals and neurotransmitters in particular. Two of those are examples are glutamate, which I mentioned earlier, which is excitatory, that will cause a change in the membrane and release ions through regions in the synaptic cleft between the excitatory input to another neuron. And there you will have sodium come into the secondary neuron and change the potential inside the secondary neuron. You have substance P, which is a large excitatory neurotransmitter in the brainstem, particularly for the laryngeal system. And nitrous oxide is another excitatory neurotransmitter. GABA is an inhibitory neurotransmitter, which, as I mentioned earlier, is rampant in areas of the cortex. And glycine is another neurotransmitter, which is also inhibitory. And there are genetic diseases where glycine has been interfered with and people have uncontrolled jerks and movements. Now, the motor neurons, which we're very concerned with controlling the laryngeal muscles, are in the brainstem, and action potentials run through the axon down to the neuromuscular junction, and there acetylcholine is the neurotransmitter that is released in the cleft between the neuron and the muscle and is necessary for producing a response in the muscle from a motor neuron. These usually fire at around 25 to 30 times per second to cause a smooth contraction. However, the laryngeal muscles are very rapid, and unless they are fired at a much more rapid rate, they will beat. And so the laryngeal muscles are interesting in that they are very rapidly contracting muscles compared to other muscles in the body, except for the eye muscles, which are the most rapidly contracting muscles in the body. Now, sensory neurons live in ganglia outside. In this case, we're talking about the sensory neurons that are in the superior laryngeal nerve, which is the primary sensory nerve coming from the laryngeal mucosa. The cell bodies for the receptors in the sensory superior laryngeal nerve are in the nodose ganglion and send projections to the brainstem to the nucleus tractus solitarius. So this is very important for the laryngeal system because we have mechanoreceptors in the laryngeal mucosa that are constantly being fired by any stimulus to that mucosa. Now, there are two systems for producing voice in the human. We have one, which is the mammalian vocalization system, and that system includes the periaqueductal gray and the brain stem. It's innate at birth and, in fact, is responsible for the birth cry. It reacts to pain and emotion, and we can study it in most mammals. And it's often unaffected in many of our voice disorders, such as the disorder of spasmodic dysphonia, where they can laugh and cry, and that's because of the mammalian vocalization system being intact. However, the vocalization system that we're most concerned with is the one that you learn, and you learn it after birth for speech and song. And it's cortically driven, and much of that is dependent on learning to speak. And that system, the cortically driven system, is the one that's affected in disorders such as spasmodic dysphonia and another speech disorder like stuttering. Now, studies were done by Jürgens for 40 years with his colleagues on the squirrel monkey, and he mapped out the mammalian vocalization system, which is innate in mammals, and found out through many studies that he could get rid of everything that's hatched in gray here, and the animal would still vocalize. This system involves the periaqueductal gray, which is just above the brain stem, and projects down to motor nuclei and interneurons in the brain stem that have the patterning to produce a mammalian vocalization. So this system, innate vocalization in animals, only requires the periaqueductal gray, the pons, and the brainstem, and doesn't involve the cortex, the cerebellum, or any of the other regions that are involved in what we learn for speech and voice. The system, the mammalian vocalization system, is controlled often by the limbic system. And here is shown the cingulate gyrus in blue and connecting down to the amygdala, also part of the limbic system. And this is very active for cries and pain and laughter, in that it's an emotionally driven and pain-driven system. And this is an example of that system that's thought to control and govern the mammalian vocalization system in the human. So emotional voice expression in humans is thought to be retained after cortical injury because it doesn't involve the cortex directly, and can be retained in patients who've had stroke or injury to the cortex. That is because the emotional vocalization comes from the cingulate down to the periaqueductal gray and then down to the brainstem. So this system can be retained when there's cortical injury and is often the reason that the patient can cry, laugh, and sometimes swear. Now let's go to brainstem mechanisms, because these are used for both emotionally driven speech as well as for the speech and voice that we learn that's controlled at the cortex. In the brain stem, there are both motor nuclei and sensory nuclei. In this diagram, it shows the motor nuclei on one side and the sensory nuclei on the other, but really they're overlaid on each side and are bilateral. There are long columns in the bottom of the brainstem at the base that's shown here in red. This is the nucleus ambiguus, which is a long column and contains all of the motor nuclei and the motor neurons for the laryngeal muscles. So we know what part of the brainstem contains the motor neurons for the laryngeal muscles, and in fact they're arrayed at different levels for different muscles. We also have that sensory system, the nucleus tractus solitarius that I mentioned to you earlier, that lies and goes along the same region. And, oops, if I can use this pointer. Well, yes. Here's your nucleus tractus solitarius, which runs along parallel to your nucleus ambiguus. Now, there are integrative systems in the brainstem that can control programs, and Jurgens and his colleagues found that there was an area just below the pons that was very integrative for vocalization, and there they found the full programming for different vocalization patterns in mammals, such as squirrel, monkey, dog, and cat, that you can find the full programming in the intrinsic brainstem in this region that will produce these innate calls when stimulated. But in the same region are several other systems. Swallow, cough, and respiration are all controlled in the same area. And this is the reticular activating system, which includes interneurons that go from the sensory input to the motor output. And this pathway is used for many different functions, not only voice, but also swallow, cough, and respiration. So we share for vocalization many of the same interneurons that are used for swallow and for respiration, which means that the breathing system and the swallowing system and the cough system all have to be interrelated with voice. The cough reflex runs through this pathway with a sensory input from the jugular ganglion in the superior laryngeal nerve, going to the nucleus tractus solitarius through this interneuron region down to the nucleus ambiguus. So it uses the same pathway as is active during voice. We have a laryngeal adductor response that also occurs to superior laryngeal nerve input, and it will produce a laryngeal adductor reflex in the thyroarytenoid muscle, which will close the larynx. This was first identified by Sasaki in the cat in 1976 and has now been well studied in humans, in awake humans. If you stimulate the superior laryngeal nerve, you'll cause a reflexive closing of the vocal folds. So this laryngeal adductor reflex uses exactly the same pathway, except it uses sensory neurons in the nodose ganglion that go to the nucleus tractus solitarius and transfer through interneurons. This is why swallowing and cough and all of these systems have to be interrelated very closely. So this is a table that shows each one of these functions: respiration, swallowing, cough, the laryngeal adductor reflex, and vocalization. And that you have sensory triggers from the superior laryngeal nerve that will induce some of these activities. For cough, you have tracheal afferents that are also in the recurrent laryngeal nerve. And for the laryngeal adductor reflex, you use glottal afferents from the superior laryngeal nerve. Each one of these systems are sensory-based in that sensory triggers can elicit the response in the brainstem motor nuclei. So, to summarize then, what we've shown thus far is that you have an emotional vocalization system that goes through from the cingulate through the periaqueductal gray down to the brain stem that will induce responses in the motor neurons. And you have a voice and speech system that's cortically based that will send responses directly down to the brain stem to the same region. So we have two systems that are probably co-activated in humans normally. Both our emotion and our learned speech system activate together, and it's only in disorders that you see their separation. This cortical bulbar system, don't know quite how that happened. This cortical bulbar system from the cortex runs from the motor area of the cortex and sends through direct fibers through the cortical bulbar tract down to the brain stem. This rapid conducting system is only present in humans, and in fact they have not been able to find it in primates, non-human primates. So this seems to be particularly salient and important for our speech system, and allows us to turn on and off control of the larynx very quickly, as quickly as 20 milliseconds. Okay, now let's look at the motor pathways from the cortex for other systems besides the voice. For other systems besides the voice, they come from one side of the motor cortex, cross over in the area of the brainstem, and then go to the motor nuclei, here in the spinal cord or the brainstem. The voice is different in that I'm going to show you evidence that we have bilateral control for the larynx, not just from one side of the brain, but also from the other side. This was first noticed by Penfield when he did mapping and was able to stimulate in one region in the left hemisphere and produce vocalization. And this was later substantiated through neuroimaging by Brown, who also identified the same region in the left cortex as very active for producing voice. Penfield found that this was the only area in the brain that he could induce voice production from human when he stimulated. Now, this same area, if you stimulate through non-invasive techniques like transcranial magnetic stimulation, if you stimulate at the cortex, you will produce a response in the laryngeal muscles at 12 milliseconds after you stimulate the cortex. That's a very rapid time to be able to go from the cortex down to the brainstem, and demonstrates this rapidly conducting pathway. And in fact, if you stimulate on the right hemisphere, you will produce a response in the left cricothyroid muscle. But if you stimulate, on the right side, but if you stimulate on the left side of the brain, you will produce a response in the same muscle at the same time. So this one muscle down here can be activated either from the right side of the brain or the left side of the brain. And that's what makes the larynx quite unique compared to other systems in the brain. So the cortical neurons that project to the brain stem via the cortical bulbar pathway into the internal capsule project very rapidly from the cortex down to the brain stem. It's bilateral control via this internal capsule projecting to both sides of the brainstem. This is why when you have a unilateral stroke, you very rarely lose your voice, because it may only be temporary in that you can unilateral lesion won't produce a loss of voice that's permanent, because the contralateral side can produce control. Now let's talk about the integration of voice with listening to voice or sound. We know from recent research that I'm going to mention that we constantly control our voice with auditory feedback. We used to think that we only use the auditory feedback to learn voice and speech, but we now know that you're constantly monitoring your voice production with the auditory system. First of all, Basal found that in the one region of the brain, the posterior superior temporal gyrus is very active for listening to just voices as opposed to other sounds. This seems to be a particularly active area that is for listening to voice, and seems to be specific to listening to voice. Now, Chuck Larson and his colleagues have shown that if they feed back somebody's voice to them and alter it, that the person will automatically adjust their voice to compensate. What they did here was move the person's voice up, and then the person automatically adjusted their voice down to compensate for that. If they moved the voice down, the person automatically adjusted it up. And depending on how much they moved it up or moved it down, the person would compensate more. So this shows an automatic, online, constant adaptation of the voice to what we hear as we speak. This is known as the dorsal stream, going from that posterior superior temporal gyrus area that's active for voice to the premotor area that's important for producing speech. And in fact, we have good evidence that that system is developed in the human brain, particularly on the left side. This is known as the arcuate fasciculus. And in the red here on the left side, you can see the arcuate fasciculus fibers going from the auditory area to the premotor area. This is on the right side. It's pretty wimpy on the right side. It's much more developed on the left side, and we think that that's actually genetically programmed in humans and may serve as the basis for our ability to listen to our voice and adapt it so quickly. So to summarize then, what's our system for speech and voice? We use the cortical system both for listening to ourselves in the posterior superior temporal gyrus, and the motor system for controlling and producing speech. We use the basal ganglia for monitoring the rate and flow of speech, and we use that periaqueductal gray region that's involved in innate vocalization in animals. So we use both the emotional system and the speech learned system. Now I'd like to turn to what are some of the abnormalities in the central nervous system that produce disorders that in this system. So first of all, I'd like to talk about the white matter that connects the brain down to the rest of the system. Using neuroimaging, you can study white matter tracts by looking at the alignment of water molecules. If these white matter tracts are robust and well aligned, you will get the water molecules to line up along them. If they're not, if they're disorganized and injured perhaps, then the water molecules don't line up. And you can use neuroimaging in awake people, even in children, to look at the alignment and development of white matter tracts and whether they've been disturbed by disease or injury. In spasmodic dysphonia, we found that those white matter tracts are actually disturbed on one side of the brain, surprisingly on the right internal capsule going from the cortex down to the brain stem. These white matter tracts were reduced on the right side in spasmodic dysphonia in a group of patients. In fact, when a patient died and we were able to study his brain after death, we found that this region was affected in this one patient that we were able to examine. So this suggests that the axons going from the cortex down to the brainstem are interfered with on one side in spasmodic dysphonia. In fact, this is that internal capsule area in a control, and this is in the patient with adductor spasmodic dysphonia where we were able to study the brain, and you can see the loss of fibers in this area. So this shows how white matter tracts can interfere with good communication from the cortex down to the brainstem and cause a disorder such as spasmodic dysphonia. Now I'd like to turn to the only central nervous system disorder that can cause a unilateral vocal fold paralysis. And this is a brainstem stroke, such as Wallenberg syndrome, where you have an injury to the brainstem, such as the communication from the sensory system down to the motor system is disrupted, and the input to the motor neurons on one side are interfered with. This is the only way you can get a unilateral vocal fold paralysis in the larynx, because this is the only time that you interfere with the motor neurons for one side of the larynx. Otherwise, you have communication from both sides of the brain. So this is the only way we can get a unilateral vocal fold paralysis. Now I'd like to talk about the basal ganglia. The basal ganglia are involved in modulation of the rate and amplitude and fluency of speech. And I will first of all want to talk about the thalamic areas, because the thalamic areas, if they're interfered with, are often involved in producing a tremorous voice. And you hear often as some people get older, they get more tremor in their voice. And this is, we think, because of involvement in the thalamus. So you can have a disorder of vocal tremor, which is part of essential tremor. It's a very common neurological disorder. In fact, at least 4 million people have tremor in the United States. It often involves the hand, and it may involve the head, the legs, and the voice. But the vocal tremor that we're particularly interested in often is genetic and affects females across generations. So you can have a fairly young woman with vocal tremor who reports that her mother and her grandmother had the same disorder. We also have vocal tremor that is associated with spasmodic dysphonia. This is called dystonic tremor because the tremor only occurs as the person goes to move. And they will get modulations in their voice between 4 and 7 hertz, and this will occur in the larynx. It can be generalized to other speech structures. Now, very famous or very common basal ganglia disorder is Parkinson's disease, which involves the striatum as well as the substantia nigra regions of the brain stem. And as this disorder progresses, it continues on up the next central nervous system to later involve the cortex. In these patients, they have hypertonicity of the laryngeal muscles. So here's a person producing the sound CE. This is a normal speaker, and you can see that these laryngeal muscles modulate as they produce the different sounds. This is the thyroarytenoid, the lateral cricoarytenoid, and this is the posterior cricoarytenoid, which has an opening function. These have closing functions. In the patient with Parkinson's disease, however, you don't see any modulation because these muscles are very active and, in fact, at a much higher rate than normal. This is a range of 0 to 400. This is a range of 0 to 2,000. So these muscles are activated to such a degree that the patient can't control them. Now I'd like to turn to disorders of sensation, because we know that disorders of sensation are very common in the larynx. An example would be cough. They can also be if you have reflux that will spill over from the esophagus into the larynx. It can cause a change in sensation as well. Now, I'd like to point out that the sensory pathways the input may come into the brainstem, as we talked about earlier, from the larynx and input to the nucleus tractus solitarius and project up to the thalamus, and for the limbs only goes to one side of the cortex. For the larynx, however, again, similar to the motor system, the sensory system goes to both sides of the brain and is very powerful in its input. So you have reticular integrative systems in the brainstem that I've already talked about that are used for swallowing and cough and breathing. These same neural substrates are activated by sensory inputs from the larynx that can provide irritation, such as cough, and activate that laryngeal adductor reflex. And that can interfere with voicing. And a very nice animal study that showed this, when they put acid on the laryngeal mucosa, they were able to produce a very high, rapid rate of muscle firing. So if you stimulate in this region, in the glottal and supraglottal areas, you will get rapid firing in the superior laryngeal nerve. If you stimulate in the trachea, you will get rapid firing of sensory nerves in the recurrent laryngeal nerve. This will produce the cough. This will induce changes in swallowing and in voice. And this is the example that I mentioned where they increased the pH, lowered the pH rather, to an acidic level and produced a very rapid increase in firing in the thyroarytenoid muscle. This would produce an adductor reflex similar to what I showed you earlier. So acid on the laryngeal mucosa can cause changes in those laryngeal muscles. In fact, there are acute changes in the laryngeal system, both with acute stimulation of a low pH, which will cause pain and irritability and throat clearing and increase the laryngeal muscles. But then with continued exposure, you'll do damage to the mucosa and lose sensation, so that the person will get a feeling of globus and feel that they aren't able to swallow, so that there are both acute and chronic changes that will affect the voice in the sensory system. Now I'd like to talk about disorders in axonal transport. We talked about neurotransmitters and sending action potentials down the axon to the muscles, and this is important for voice as well. We have to be able to have good release of neurotransmitters into the synaptic cleft to be able to fire either the muscle or another neuron from the primary neuron. There are diseases where the release or transcription of different genes can be altered and reduce protein synthesis and change the level of neurotransmitters available between neurons. The nucleus has several transmitters that have to go down the axon, and then after they're released, you have to have other nutrients come back to the neuron to produce more neurotransmitters. So if you have a change in the genetic programming, you might not have the normal transport of things down the axon or back up the axon. And in fact, we found that this can affect the larynx because the recurrent nerve is a long nerve, and if you have genetic abnormalities that change this transport, you can interfere with the laryngeal muscles. Here's an example of a disease in the brainstem where a patient has had accumulation of proteins in the motor neurons that causes death and makes them with inclusions quite different from the control. So here are examples of patients who have the affected ability so that they can no longer open the vocal folds for breathing and close them for phonation, the same as normal. And this is because of genetic abnormalities affecting the recurrent nerve and the laryngeal muscles. Now, finally, I want to mention very briefly that this whole system that I've talked about, both at the brainstem, the cortex, the basal ganglia, and in the peripheral, can be affected by function. It's highly plastic. That is, as you use it more or as you change your use of it, it will alter as well. We know that you can change the function of neurons and the synaptic plasticity between neurons. You can potentiate the ability of one neuron to fire another neuron. By using the connections between two neurons, you will have greater plasticity and greater ability of one neuron to fire the other. You can have growth and regeneration of neurons. We used to think that all we did as we got older was lose neurons. We now know that parts of the central nervous system can cause new neurons to grow. We can change the myelination or covering of neurons, and that is a result of certain cells that can grow. Axons can grow. If you injure the end of a nerve, it will grow back. And we now know that the recurrent nerve in most cases will grow back unless the lesion involves the whole vagus. Dendrites will grow more with use, and glia, which are involved in some of the covering of the neurons, will also be activated and cover the neurons more. Here's an example of cortical plasticity. This is where the differences that are shown, the areas of the brain that are shown in red and yellow, are areas that were more active in musicians than in controls. And this is the area of hand representation, which makes sense for musicians, in that these areas were much more active in musicians than in controls. This is the result of many years of practicing, showing a change in brain function. And we now know that there's also a change in brain structure the more you use it. The cortical regions can grow or shrink depending on how much you use them. This is an example of juggling training. This is the amount of activity in the brain before the training. This is the amount of activity in the brain after the training. So the amount of, this isn't activity, this is gray matter volume. So these are structural changes after use. So after learning to juggle, the gray matter volume, that is the volume in the cortex, changed with the juggling training. However, if people no longer juggled, this reduced to some degree. So the old axiom of use it or lose it is extremely important for the brain. So to summarize then, yes, the structure of the muscles, the laryngeal muscles, and the function of setting them into vibration is very important. But I would like to propose that without this organ up here, the brain, none of that will work. Thank you for listening. Do we have time for questions, or should we leave it now? Okay, so we'll have a break. We're asking you to come back at 5:05, is that right? And you're going to hear Ron Scherer. Thanks very much for listening.
Yes. Are you going right after the?
I'm second.
Ron's going to go first.
Here we go.
Put you on. You'll be on 3.
Okay.
So there are 3 more, me, and then Johan, and then Rahul. Is Rahul using his own computer?
He hasn't come to us yet.
Rahul. I thought I just heard you on that.
You did. Rahul.
So there's only 2 computers. This one, but then mine. I would like to use mine.
Mm-hmm.
So,
and I'm the next speaker.
Rahul?
Rahul is going. He has a drive.
Wikipedia.
Yeah. And so we need to select mine. How do you want to do this? Just put it on top of this guy?
Yeah, wait for him to put it on, because that computer controls this one, and then we'll put it on top. And then, is he going last?
Yes.
All right, well then, and we'll just open this up. or he can open this up.
Just lift the lid.
Yeah, once the
Just put it on standby or something.
Yeah, once that document pops up there from that on there, we can close this, and you just put your computer on top there. We'll put you in number 2.
Oh, good. I'm already plugged in.
And you should be good to go.
I'm done.
You're done already?
Yep.
It's amazing.
You can do it. You don't say anything.
I'll be right back.
Thank you. Yeah.
You have sound?
I have a little.
Okay.
I'm not sure.
Look better.
It's a main thing, isn't it? But should this be video and
Yes,
this
sound.
audio? You have sound on me? Well, whatever. I have sound.
Is that it? Yeah. Okay. Very good.
Really? That's stupid.
There's sound on this one. Can we test the sound on this? Well, let's see. When I play it on mine, it's normal loudness off of my laptop. But let's check. So what do you think? Did you check Johan's computer for the sound?
No, not yet.
He's going to have a lot of sounds. Here's the sounds and audio.
This is for the, it should be a mixer. Yeah, it was fine a minute ago. Did you change the resolution? Let's get out of this. Yeah, he's up all the way.
That's good to hear.
There you go.
What'd you double click?
Okay.
The paper. Oh. Well, they could certainly, if there's space, they could put it up and we just don't judge it. Just let them have it. What is it? Actually, one guy, I might be able to get somebody to some knowledge of it. Yeah. May or may not. Give it the, can you give it the like the last number or something? One more number? And we'll check it out. Give me a note about what it is.
Yeah.
I'll see if I can get some people. If not, if it looks like a really, really good poster, I'll be sure to go.
Yeah, she's
Oh, okay.
yeah. All right. That's it.
Thank you. Yeah, just give me the information.
John, sound. Okay.
Do you have any other? Do you have any?
Good try mine. Yeah.
It's really low. Yeah, it's really low.
Not when you put in speakers at our place.
This is you. Oh, I mean like.
That's actually pretty low. Okay. I'm more concerned about Johan's. This sound is not as important.
Do you want me to switch to the podium? going to use the podium one.
Not the one that was on. Not that one.
Okay.
This one from
This is from the first.
podium,
okay.
yeah.
There you go.
Is he,
He's muting it.
oh, he was muting it. Oh, okay. Oh, you should check, can he check test his audio?
Yes. Yeah. Well, as soon as he comes up, we'll just plug it. As soon as he's got it set up, we'll plug it in.
Just plug this in.
Yes. We're going to test Johan's audio, Dan.
Just keep your computer here. Who's going to plug this into you? Let's see.
If you could, I can't. Hold on a second. Yeah, can you get this over there? This is for Dan, the podium. Dan. This one in. He's good. You heard him. So.
Yep. You do it, and then what do we do then? I just put this down and this comes up?
Yeah, you might want to just unscrew it in the back, and then you get more.
Okay.
And he's good. You're on.
He's already plugged in. Or is he going to 2?
So he's on 3. So I'll come up and
Good,
we'll
good.
all work together.
Yeah. Welcome back. I think we will get started. Hope you had a good break. Hope they have good food over there. Hope you see all the exhibits this week. And we're going to continue then with some aspects that are listed here. And then Johan is going to talk about acoustics. And then Rahul is going to talk about perception. So it's a long, great day, I hope. And it's tonight sometime. We'll have Q&A after the 3 talks. How many of you have been to these tutorials before? Actually, how many are new? How many are new? Oh, welcome to the symposium. Typically, I talk a lot about oscillation and vocal folds and all that, and because Sten Turnstrom is not here this year for the tutorial, Johan and I split up our obligations. So I'm going to actually do something different this year. I'm going to talk about 3 concepts that are pretty important to the rest of the talks this week. One is dealing with elasticity. Elasticity is actually fairly pervasive this week in many of the talks, and we've never talked about it here in the tutorial. And then some respiratory basics for control of airflow and air pressures. And then another reminder about video chemography, which is toward this high-speed stuff. So let's talk about elasticity. As I said, many topics this week on elasticity, biomechanics, nonlinear mechanical aspects, dehydration, all these aspects that deal with tissue and the use of the body to make sounds and air pressures deal with elasticity. So we need to have a closer, deeper orientation to it because our profession is only going to have, our professions only is going to be talking about this more and more. If you take a rubber band and stretch it, it expands and then contracts. And this elasticity is a physical property of the material. It means that once you stretch it with a pressure or a force, and then let that pressure or force go, it will return to its prior state of length and shape. And so How do we actually define, though, elasticity and understand it? Because that's what we as listeners this week are going to have to try to get a hold of when all these engineers and other people talk about elasticity. Well, let's consider an example. Actually, on second thought, let's consider a different example, one that's a little more simple. Here, let's take a piece of tissue, and actually they do this with vocal folds and other tissue. They'll take like a cylinder or so of it, attach it to a wall, and then measure the length, L, of that tissue. That tissue sample also will have a cross-sectional area, A. These are two very important aspects. Tie a line or attach a line to the end of that material, and then hang it over a pulley, and allow it to hang there so the original length L is there. But we are going to, in the next slide, apply a force to pull and stretch that material, because elasticity is all about stretchiness. Now, add a force so that you actually pull. Now notice this is elongating that tissue by a delta L, a small change perhaps in the length of that tissue. I would like you to be thinking, for example, vocal fold length increase as you pull with a force due to cricothyroid contraction, which is an external force. This is a perfect analogy to that. So now we have force applied, and the length of the vocal fold, the length of this tissue is longer. Now the length is L plus delta L. There's still a cross-sectional area, but we'll note pretty quickly that if you have, like the vocal fold or a piece of tissue or a rubber band, if you take that rubber band and stretch it, you'll notice that the rubber band reduces in the cross-sectional area. It becomes thinner, doesn't it? So you have this rubber band, and there's a certain amount of volume to it, and if you elongate it, the volume did not increase or decrease much. Assume it didn't increase and decrease any. And so it's going to have to change in cross-sectional area, that is, become less in cross-sectional area. You've heard a lot about stretching the vocal folds thins the cross-sectional area of the vocal fold. Now let's define the word stress, a very important word, S-T-R-E-S-S. It is defined by the pulling force F divided by that cross-sectional area A on which that force was placed. So this is stress. We have to understand this word stress in order to get all this. Stress is the force divided by the area. Notice this is actually a pressure term, force divided by area. Remember that? So it's really got pressure units. So stress is like a pressure. Force divided by area. Another term that we have to come to grips with is the word strain. Strain really refers to this elongation, but now you take that new length, L plus delta L, and divide by the original length. So this is like the incremental length. Strain is an incremental length. For example, if the original length were 10 millimeters, and you increase the length by 1 millimeter, that would be 11 millimeters, and you divide by the original 10. 11 over 10, that's 1.1. You could also express that as a 10% increase in the length, couldn't you, right? So now we have stress defined, the force that we apply divided by the cross-sectional area of the material, and the strain, which is that incremental, the new length divided by the original length. Now, people like to graph stress and strain, and that's what we need to understand also. On the x-axis, put the strain, this incremental length, and on the y-axis, put the stress, this force divided by area. Now, make a measurement, create a new force, and get a new length. So now, graph the first point here, which is now a strain, an incremental length, corresponding to the new stress that came from applying the force. But you have to, in these experiments, and they do these, Fari Alipour is here, he does these all the time. We're going to show a graph of his in just a minute. He has to actually calculate what the cross-sectional area is, as well as measure that force. So keep that in mind. So this is not that easy for these guys. Now, do it again, put another force on and elongate the tissue again, you'll get another point. And then do that consecutively, and you'll get a series of points where you have applied new values of force to stretch the material, and you get new lengths, new stretches. Now, it could be that these line up into a straight line. This is very important, a straight line connecting the points. This is called linear. All those engineers that talk about linear and nonlinear dynamics, etc. Linear means that if they have a variable on the x-axis, a variable on the y-axis, and all those points form a straight line, that's called linear. And if they don't form a straight line, it's called nonlinear. So when you hear nonlinear, don't get bent out of shape. It just means that it's just not straight line, the relationship. Now, if you have a straight line, the slope is constant on that line, isn't it? Anywhere on that line, the slope is constant. Well, if this is the case for material, and it is for especially small changes in material, this is a linear relationship where the slope is constant, and notice the slope, rise over run, is stress, which is the rise of the y-axis, divided by strain, which is a change on the x-axis. If it's a straight line, the slope is stress divided by strain. And that relationship, that stress divided by strain, that slope is constant when the line is straight. Well, that's a special case of something. If it's a straight line with a constant slope, that slope is called E, usually, capital E. That's the important thing. And it's also called Young's modulus. There's a guy who became famous for it. Somebody else did it before him, but I don't know why, politics. So this constant slope, the slope is called Young's modulus. That's a big word. You'll hear that this week sometime. Now, so E is actually the stress divided by strain. And if you now multiply both sides of that little equation by strain, you get, I'm pointing, I just hate this when I do this. I'm pointing to my, can't you see? But it's actually where the little white guy is there. So anyway, stress now is equal to E times strain. And that relationship is called Hooke's law. So now you know. There's no big deal. Quite often, instead of stress, they'll use sigma. Instead of strain, they'll use epsilon or little e. So sigma equals E epsilon or little e. So you'll see that maybe this week. Is the stress-strain relationship linear for the vocal folds? In fact, yes, for small changes, but otherwise it isn't. Here are data from Fari Alipour. This is actually measuring strain on the x-axis here versus stress for a number of cases of a pig vocal fold. And what I've done here with the little dots here, this is his average of all these cases. If you look at the very beginning, if you just take a few of these dots, it's pretty linear. So Hooke's law, that linear relationship, actually can be applied to small ranges, especially at the beginning. But we notice that this is curvilinear. This is nonlinear. It curves. In fact, it curves upward, which is very, very important. So it's not linear. And secondly, stress increases faster than length increases. This is a very important topic, especially when we're not going to talk about it today because we don't have time. But when you talk about explanations of fundamental frequency rise, you want to keep this in mind. So when you read that literature, keep this in mind. The stress increases faster than the length. For example, I've drawn two lines here at 15%, 30%, and they're cutting these little balls here at different places. So at 15%, it's 4.5 kilopascal for the stress. And if you stretch it another 15% of the original length, just 15% more of the original length, the stress rises to 12.5, which is 277% rise. So the stress rises faster than the length. Keep that in mind when you see equations that have length and stress. Okay. Now, you can also, Fari also said, for example, take this rubber band and go, wow, 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 I go, wow, wow, wow. You can dynamically stretch. So if I go, I'm cricothyroing, more, So I'm actually stretching back and forth, and you want to ask yourself, well, what's the length-stress relationship there? In fact, it's dynamic. If you elongate going up, and you hit a particular displacement or lengthening, it takes more force, more stress, than when you come back down and hit that same, in this case, it's displacement. There's what's called hysteresis. So the word hysteresis means that on the outgoing track, it's a different function than on the downgoing track. This is going out, it's above, and going down, it's below. That's called hysteresis. So now you got the vocabulary, and when these guys talk about these things, oh yeah, I heard about that. Wednesday, wasn't it? So elasticity is a property that is a restoring force. We're going to talk about respiration, and it's a restoring force. Elasticity is pervasive. It's studied by comparing the strain, which is the increase in length, to the stress, which is the pressure applied. And you divide those. It is nonlinear for human soft tissue, meaning that stress increases faster than length. Engineers love this. If it were not for elasticity, we would most likely fall apart or droop more than we already do. Okay, so now let's move on to breathing. Some basic concepts. All right, so everybody do this. You are now at REL, resting expiratory level. And if you go, and your airway is open, and the air pressure in your airways is the same pressure as out here, atmospheric pressure, because the airway is open and there's no air movement. Now, this is called your poor man's animation. So now you begin to expand the lungs by activation of muscles, and that volume increases. The pressure inside, air pressure, is negative, and so it's less than what it is out in the room. That pressure difference pulls air in. So inhalation is when you increase the volume of the lung and air rushes in, and at the top of that inhalation, something happens to that pressure. So do this, go and make noise so you can hear yourself. Do that, and stop. Now you've stopped, you've expanded, you have more air in, but now there's again no air movement. Airways open. So now right there, the air pressure in your airways is again atmospheric, because there's no movement of the air. This is a mystery. And now, breathe out, make some noise. So when you begin to exhale, the volume of your lung is decreased on purpose, and the air pressure inside, because of that, is now positive. It's higher than outside. That pressure difference makes the air exit your body, and that continues until you get down again to that REL, where again it's zero everywhere. So the pressures are negative and they change. They have a maximum, and then they go to zero as you inhale. Then as you exhale, the pressures are positive, there's a maximum, and then they go to zero again when you stop. So that's fun. We have the larynx. The vocal folds usually are separated when you're trying to inhale. Otherwise, you may have paradoxical vocal fold motion. Stridor. Here we have the trachea and the primary bronchi, secondary, and there are many generations, about 20 or 21 generations. You can count each one here. Here's the trachea, here's primary bronchi, and then you can't count them. This goes all the way down to the alveoli almost. So actually, when you get down to lower generations, you get into the areas where you can exchange gases, and you get where the alveoli are, and these are then surface barriers where you have gas exchange of oxygen and carbon dioxide. Here we have a few ribs. This guy has the normal number. There are 12. A couple of them float, but don't tell them. That's a secret. You're all familiar with this. So we have the sternum. You can always hit your sternum. That's always fun. Here's the clavicle. We talk about clavicular breathing, but it's not the clavicle breathing. That's really, I think, so funny. It's just that it moves when you inhale in the upper chest, and people say, don't do that if you're trying to train. But if you need air, do it. We have muscles of breathing, the external intercostals. Everybody take your hands like this. Don't hurt anybody to your side. Face them down and in. And this is like the external intercostal muscles. When they contract, we mimic that by just bending your fingers. Just bend your fingers when they contract. And then kind of lift up as if that raises your rib cage. So that expands the chest and expands the lungs, and air comes in. The internal intercostals, now take your fingers like this, and they're going across the externals like 90 degrees or so, and then like curl your fingers, as if they're contracting. Then you have to do this kind of thing to make it all worthwhile. And that's exhalation. So external intercostals are for inhalation, expansion, internals for contraction or expiration. Around the abdominal area, we have a number of muscles, external oblique, internal oblique, rectus, and also transverse. When they contract, they make the circumference of the abdominal area smaller. The pelvis doesn't move, hopefully, unless you really got a problem. But above is the diaphragm, and so when the abdominal muscles contract, they move the contents of the abdominal chamber up and push the diaphragm up. So contracting abdominal muscles is an exhalatory motion, trying to reduce the volume of the lung. And we also have the diaphragm, very large dome shape, connected to the ribs, etc. When it contracts, it moves down. And so we have a very important, from a pedagogical training and just normal, how do you do it, a point of view, these opposing forces. The externals expand the rib cage, internals contracted, expansion, contraction of the lungs. The diaphragm pulls down and expands the lung, but abdominal muscle contraction makes it rise, creating smaller lung volume. So we have direct antagonistic relations as well as secondary. And when we talk about control for speech and singing, this is of paramount importance. So for direct antagonistic action, the externals, when they fire, will expand the lung. Internals will contract the lung volume. Relative to the position of the diaphragm itself pulls itself down when it contracts, and the diaphragm goes up when the abdominal muscles contract. These are antagonistic actions for air and pressure management. We control these when we speak. Everybody does. And the optimal control for performance, public speaking, etc., is kind of unknown. You certainly don't want to have high muscle tone in these antagonistic muscle groups, otherwise you won't move anywhere. That's like getting really rigid and say, okay, now to try to do something fast. And you can't be so floppy, low muscle tone that nothing can get done. So there are optimizations, and we won't talk about that here because I don't know it. But it's a good question, and that's what pedagogy is all about. Secondarily, we have the external intercostals, which would expand and the lungs, and the abdominal muscles below, spatially separated, contracting, that would allow flow to come out. These are opposite, and you can do this simultaneously. In fact, when I ask my students, okay, I want everybody to take in a lot of air real quick. Everybody do that. Just go like that. Go. Well, about 90% of my students, they'll have their abdomen come in and their chest expand. And I said, well, that is called paradoxical motion because you wanted to have more air in. So if your real goal was to maximize how much air would come in, you would want the diaphragm to go down and expand while the externals contract. So you had, and singers, and actors are taught this sort of thing. But I think this reluctance to do that, this paradoxical motion, probably sets you into, I have to have oxygen, and I also have to have my core so I can run away. So I think that's what it is. So I don't, blame anybody for doing that. Now, if you close your glottis, everybody do this. Take in some air, close your glottis, and do isovolumetric. So you shift what's wider, what's more circumferential. So take in some air, and then do this. That's isovolume maneuvers. That's actually used in calibration of certain equipment. And this is taking advantage of these paradoxical motions here. So that's another aspect of the overall control strategies that we have to have. How do we use these for what purpose? Moving on, vital capacity is actually all the air you can exhale after you have inhaled all the air you can. I just love that. And usually it's 0 to 100% vital capacity. That's the air that you can actually use. Now, let's talk about something that's really important, I think, in understanding all this aspect of breath control, pedagogy, clinical stuff. Everybody went down to REL. Do it again. So we have expired. We are now relaxing all of our muscles without falling over. And the air is at a certain level. I love this term, resting expiratory level. Finally, we have a term that makes sense. Now, that is when the air pressure in your body is 0 at REL. And so here's 0 pressure here. This is going to be air pressure in your body, in your airways. And it turns out that this is about 40% of your vital capacity. You could exhale more. You could inhale more. So this is at 40%. I borrowed this part of the slide from Johan. So watch the. I'm pointing again. Watch this REL. That was from Johan. Gave me his slides. So I'm using a couple of them. Anyway, now take in. I would like you to do this. Take in a lot of air. Then close your mouth and velum so no air can come out, and relax. It's going to look like this. Okay, everybody do that? Now, feel the pressure before you let it go. And when you let it go, after you've relaxed, that means that there was pressure built up because you had inspired, you closed off, and then you relaxed at a high lung volume. So that would be this point. You inhale a great deal, almost to the top of your vital capacity. You close your mouth, your velum, no air can get out, and you relax. And the pressure builds up. Your cheeks balloon out. If you had a little manometer, he's got a side joke there. You could measure the pressure in your airway. Now, so this is called relaxation pressure curve. Why? Because you inhale, close off, relax, and you get a pressure in your airway. It's a relaxation curve. Isn't that cool? I think it's lovely. Now, do that at many different levels of air in your body, and you can chart out this relaxation pressure curve. Also, you can exhale air, close off, and get negative pressure to fill out that line. Now we're supposed to understand that this relaxation pressure is there. You can't do anything about it except counter it and control against it. So if I inhale, close off, and relax, I'm going to make a sound that's kind of loud because there's pressure built up just from that recoil, no muscle function, just from the recoil, because it's relaxation pressure. Do that. Close off, relax, and then just let it go to make a little sound. You have to open the glottis slowly so that you have to make a sound. Okay. Try that on your own. Now, so this is now where a person has inhaled a lot. He's going to create at a constant lung pressure a long that's nice to say, for a long time. So he tanks up, and at constant intensity and quality, the air is going to come out of his body at a constant rate while he maintains a long sound. Now, that is this red line that intersects this curvy line, which is the relaxation pressure line. That is, at 8 centimeters of water now is the desired phonatory lung pressure. But the person inhales a great deal. But as we just learned, the relaxation pressure at high lung volume is a lot. In fact, it's like 40 almost centimeters of water. So how does he now produce this pressure here that he wants rather than this too much pressure, which would make it very loud? That person has to counter by using inspiratory muscle contraction. In fact, net inspiratory muscle contraction, meaning that you have to have much more inspiratory action than expiratory. Now, I'm going to let us experience this as easily, hopefully, as we can. And that might be the following. As you inhale slowly, I want you to feel that you are using inspiratory muscles. You're working to inhale to almost your highest level of lung volume. And just experience that. Here we go. Okay, and if you hold that, you're holding with inspiratory muscle function. Okay? Now relax. In fact, for people who have weak inspiratory muscles, they have regimens where they increase the strength of those muscles by doing inhalation exercises. Now the idea is to, at the top of that, make a kind of a relatively soft sound. It'd be like this. And I want you to do that. And I want you to do that when you start making the sound. I want you to feel that you still are using inspiratory muscle action. Here we go. Relax. Okay? Now do this. Close the glottis and relax and feel now inside the relaxation pressure that you would have right at the tip of this arrow. Here we go. Okay? So I think what you want to feel is that you have to maintain inspiratory muscle action to control this lung pressure and therefore that loudness. Do it again. All right? Now, air comes out of the body. That means you're going down this line here at that constant loudness. And you eventually get to this point here where the subglottal pressure, lung pressure that you are using, that you desire to use, is now the same as the relaxation pressure that the body gives you at this lung volume. Now you don't have to be using a net inspiratory or expiratory. That muscle contraction business might be equal between inspiratory and expiratory, but the pressure that you're actually using is actually the relaxation pressure. And then when you continue to expire, your volume of lung goes down and down and down, and you have to now use expiratory muscle function in order to produce the sound. Why? Because this is a negative pressure. It wants to suck in air, but you're still trying to drive. So exhale all the way almost. And now go, close your glottis. Relax, and then so you have to counter this negative pressure by using net expiratory force. Now here is the crux muscularly from Tom Hickson. Here is where we start at the top, and we have net inspiratory muscle action. Here's the diaphragm contraction, the inspiratory ribcage muscle contraction. This next line is expiratory ribcage, and the lowest is abdominal wall. Now, these two are giving you the inspiratory muscle contraction, right? Diaphragm and the externals. They are countering this point right there, which is the large pressure due to relaxation pressure. You have to check against that by using a lot of inspiratory muscle function. But notice that you might actually be starting to use a little abdominal wall, which is the other direction. So right off the bat, there's antagonistic action to control, but you have a net inspiratory muscle effort, muscle force. See that? And this antagonistic action is prominent. We use it all the time when we're performing to control the system best. Now, this is a little more air is out, and now this is time going left to right. So now, in this diagram, the diaphragm doesn't have to work. I would suggest that for singers, it still is working for control. And you have less inspiratory from the rib cage, and a little bit more from the abdominal wall, but it's still net inspiratory. This muscle is contracting more than that in the sense of the effect. When we get down to here, this is now where the inspiratory muscle force is exactly the same as the expiratory, so there's no net inspiratory, expiratory muscle contraction. The pressure from the relaxation is enough. Down here at actually REL, this person's still phonating at this 8 centimeters of water, and now actually it's turned to net expiratory force. You have to add to the relaxation pressure. And when you get down to here, you have to add more to it using expiratory muscle function. And way down here, you're really pushing to make that 8 centimeters of water. If you are louder, which is this number 3, you start louder, you don't need as much of this checking action, but you cross this line sooner, so you'll need a lot more expiratory muscle function. And again, there are those in the room actually who deal with expiratory muscle strengthening. Now, speech varies the subglottal pressure. Speech on stage varies it a great deal more, and when you're singing, it's a great deal of change. So to summarize this aspect, this relaxation pressure is always there, but it depends completely on the lung volume. So you always are dealing in a complex way with the relaxation pressure. You are always using net inspiratory and expiratory forces to counter, to get the pressures that you want for stress in speech, for the loudness that you want, etc. This is a very antagonistic muscle situation for airflow and air pressure management, and it changes all the time. It's very dynamic. You can't get away from the dynamic aspect of this. Now, I think this is one reason why, if you line up 300 people who teach some aspect of breath control, they'll all have a different view about all this. because it's too complex. So it's better to understand the complexity and make our language fit that and our pedagogies fit that, etc. Now, I'm going to have to stop, but watch this. This is video chemography because we don't have mirror images of the vocal folds, and the vocal folds move left to right, and here they are moving left to right. And in chemography, it looks at the motion left to right at a particular line on the figure here. And right here, the upper edges are separating. And what I want to point out right here is that at this point here, believe me, because we didn't have time to do this pedagogically, sorry about this, the left side, the left vocal fold has gone to its maximum position before the right is. That's what this means here. This point here, the left vocal fold has maxed out its position before the right does, which is here. So chemography, which is this other topic this week about high-speed this and high-speed that, chemography is going to be adapted more and more in the clinic to look at specific locations across the glottis, asymmetries of motion and the consequences of that to sound production, to the aerodynamics, to perturbations, and to modeling. So thank you very much, and Johan is coming up now. Why don't you do that? I'll just take this away.
So this is the code. Okay. And then we have the sound right now. And I will unplug that all of a sudden during the experiments. Should be good. Okay. And once again. Yep. Good evening. I am going to talk about the resonance and voice acoustics, and my talk will consist of 6 small compartment resonance, vocal tract resonance equals formants, and the formant frequencies are tuned by the vocal tract shape, and the formants determine vowels, and they determine the consonants, and they contribute to the personal voice timbre. So this is the instrument that you know very well now from Bob Sataloff's talk, and an important aspect of acoustics is frequency and amplitude. So you ask me, what is frequency? And the answer is, how often? That is the answer to the word frequency. It is how often things happen. Another aspect of acoustics is amplitude. So what is amplitude? And the answer to the question is, it is how far away from the equilibrium do you travel with pressure, with movement, or whatever. Okay, so what is resonance? The basic phenomenon of resonance is that sound is reflected. And it is reflected not only at the close end of a tube. Imagine that we have the vocal folds here and the mouth opening here. So when the sound is generated here, it travels all the way to the lip opening, and there it is astonishingly enough reflected back. So it travels back and forth here. And that is, let's see, what is resonant was the question. And I have another answer also. You stand in front of a long field and you clap your hands, and after a little while the echo returns. And then if you clap your hand again, exactly at the moment when the echo returns, you will have lots of sound for little effort, because there is a harmony that the echo helps the sound that you produce with the new hand clap. You could do this with a tube. If you have a long tube, you will clap it in the end, and you will hear the sound coming back. And if you then clap the end at the same time as the returning sound comes, then you have resonance, then you have hit the resonance. And you will imagine that if you hit it a bit faster than the returns of the reflected sound comes, then you won't get this bargain of much sound for little effort. So then you are not at the resonance frequency. You could also imagine that you could hit the long tube in this rate, but you could also do it twice as fast, and you could still have synchrony between returning sound and your hand clapping. So resonance occurs not only at one frequency, it also occurs at several frequencies. Now let's imagine that the sound waves that belong to the voice source, the transglottal airflow, the pulsating transglottal airflow. It's built up by a series of harmonic partials, and they all try to get through the vocal tract. But this is not so easy for every frequency. And I would try to demonstrate this by means of trying to put in a lot of frequencies one at a time in a tube, and then I discard that, and then I take the sound here from yes, this is a earphone, and it's sitting here in plasticity clay, so I could make a tight connection here, and then let me start with demonstrating the sound generator, which is sitting here. So I could switch that on and get some sound. It's not very loud, but and if I go down with this. Okay, so I will try to send this simple tone into the simple tube, and then you will see, well, first of all, you will expect that the sound will become very loud when the reflected sound harmonizes with the input sound. And if this is going to work, it will work. Let's see. I should then try different frequencies. This is what I'm... Oh, yeah. Yeah. Here we have rather loud sound, and if I go down, it's softer. So that was a peak. The tube loved this frequency. Okay, and there was another one down here. Soft. Loud. Okay? Am I right? Okay. So that was the end of that little experiment. What I was doing was like this. I had a sound, a simple tone that I was sending through the... I need to switch this off. Otherwise it would... I was sending this simple tone, which was gliding in frequency from low to high, and we heard that it was becoming loud at certain frequencies, the resonance frequency of this tube, and there were more than one resonance frequency we could listen to two. Okay, so resonance occurs at frequency at which input and reflected sound are in phase so that they help each other, and the result is excellent transmission and loud sound. And in the vocal tract, we have at least 5 important vocal tract resonances, and they occur at certain frequencies, and they are numbered. The lowest is the first, for instance. That was the end of that story. Now let's go to the second story. That is that vocal tract resonances are called formants, but they are actually nothing but vocal tract resonances. But you could imagine that if we have the voice source composed by a spectrum, harmonic spectrum of sinusoids, all of them try to swim through the vocal tract, but the vocal tract is like a crazy equalizer. So it enhances certain frequency, which is the resonance frequencies or the formant frequency, and attenuates the other frequencies. So this partial comes right in the peak here of the frequency curve at resonance, and that will then be radiated at a big amplitude in the spectrum leaving the mouth, while the fundamental in this case is in the skirt, so that will be attenuated and be not so strong in the radiated sound. 4 terms to remember: vocal tract is pharynx and mouth cavity. Glottis is the slit between the vocal folds, as Bob Sataloff explained, and the formant is a vocal tract resonance and produces a peak in the frequency curve. Now let me show you my spectrum. It is sitting over here, and I hope that it is running. I have a microphone here, and I could... Yeah, you see... this is a whistle tone that I was producing, but if I produce a more complex sound, you see peaks and valleys, 2 of them at least, and perhaps a third little one down there, which is then exactly what I was referring to in my graph. This one, you see peaks and valleys in the radiated spectrum. And now I will do another little experiment, and that will take the same cylindrical tube and let a pulsating airflow pass through it. Yes, this is a pulsating airflow because it is a duck call, and it has a vibrating membrane here. So when you blow here, the membrane starts to shut off and open the way for the airflow, and this is the poetic sound produced by that. And if I now combine that, pass this boring sound through the tube, I get not but I get So I get the vowel quality because the transglottal airflow, the pulsating airflow, is filtered by the vocal tract resonances. So the result is a vowel-like sound. That was the end of that story. Now I take the third one. The formant frequencies are tuned by vocal tract shape. Then I think I need to convince you by doing the following experiment. I have here the pulsating airflow, and then I pass it through a flexible tube that I could make narrow in the pharyngeal end, or in the middle, or and then as I said, the formant frequencies are determined. This will change the formant frequencies because the formant frequencies are determined by the vocal tract shape, and that shape changes when I squeeze the tube. So is and then when I squeeze it in the pharyngeal end, it is and in the front end it is and if I squeeze it in the middle and in the middle and the front, and then I could switch between pharyngeal and palatal, pharyngeal and oral. That is quite natural and positive in Swedish, actually. It means yes. Okay, so I get vowel-like sounds, and if we look at what we are doing when we produce different vowel sounds, you could feel that when you say an E, you have a narrow oral cavity, and that means that the tongue is busy here in the front of the mouth, so there is lots of space in the back of in the pharynx. And here is a selection of vocal tract shapes. E and E have similar tongue shapes, but the jaw opening is a bit bigger in E than in E. U is produced with a squeezing of the middle of the tube together with the squeezing of at the front end, and O is a squeezing in the upper part of the pharynx, and A is a squeezing of the lower part of the pharynx. Yeah, now let's go to the next point, which is that the formant frequencies determine the vowels. This is the code that we have, and here you see the first vocal tract resonance, the first formant frequency plotted as function of the second formant frequency, or vice versa. So when we say oo, we have a first formant of about 300 hertz, and at the same time the second formant is located at 700 hertz. And if we increase the first formant to, say, 800 hertz, and the second to 11 or 1200 hertz, we get A. And if we increase the second a bit more, we get A. And up here, we get E. So this is a very surprising thing. So maybe I should convince you even more by running a double experiment here. I would like to have now, I would like to have the spectrum analyzer look at what a synthesizer is doing, and synthesizer is called Madde and sounds like this. Yes, so it is here I can vary the frequencies of the formants. So here we go. Monotonous maybe, but it is also possible to do the same thing with the same kind of representation that we had in the formant maps, with the first formant along this axis and the second along this axis. So if we now ask Madde to start with singing, and 300 and 700. I now was inviting you to was a sort of crusade in the archipelago of this formant chart, where we tried the different combinations of the first and second formant frequency. Okay, so there were two lowest formants. I just changed the two lowest formants, and that gave me all the vowels that I would need for speech. Summarizing, formants occur at certain frequencies, and they are determined by vocal tract shape, and they determine vowel quality. We can change vocal tract shape by means of articulation, and there is a program called Apex, that is nice to do. All these programs are available for free on the internet, by the way. Here I could, I think I should set the a nice voice source. So yes, and it could get an eye also. Doesn't change the sound. I could increase the jaw opening and get and I could get put the tongue towards the back pharynx wall, and then I get and here I get something else, or with a smaller jaw opening, or with a spread lip. Okay, so that you could convince your friends that the vocal tract shape is crucial to what you are going to say. These are the articulatory tools: the jaw opening, the lip opening, the tongue body shape, the tongue tip, and the larynx position. Those are the main means we have to change the articulation. Formants and personal voice quality. Vocal tract dimensions differ between people. So some people are very small, we call them children, and they have very short vocal tracts. So instead of saying, you could combine that with a short tube, and then we get something quite different in voice timbre. Like a very, very hoarse child. But children generally have shorter vocal folds also, and that gives them a higher fundamental frequency. So that is more like small people. Okay, the higher formants are also crucial to voice quality, and I should perhaps demonstrate that by means of the synthesizer here. Let me run through, and what I'm going to do is just change the upper format. I won't do anything with the lower ones. So here we go. This is the timbre shifts, the personality shifts if I change the upper formants, the third, fourth, and fifth. Okay, this is the a bit vulgar, but it is still a touch of truth. First formant is very sensitive to what would you do with the jaw opening. So a wide jaw opening raises the first formant. The second formant is very sensitive to what you do with the tongue shape. So if you do front tongue bulging, then you come with a high frequency of the second formant. And these higher formants are more dependent upon the details of the vocal tract. Formants also determine consonants, and this is very important. So let's look at the consonant like B, like in boy. When we do this, this is the first formant plotted versus time. This is the second. So the second formant dips and goes down, and then we occlude the lips, so there would be no sound for a little while, or a weak sound, and then they go back up through them when they say y, b, and the third formant is following the same pattern. But what happens if I say another consonant? Well, this is y, d, and here you see that the difference is not so much in the first formant, but rather in the second and in the third, because the third goes up when you say D, but it goes down when you say B. And if you say gay, g, then they pinch each other, the third and the second. So what I'm trying to say is that each consonant has its own profile in movements of formants. And if you are sloppy with these movements, you won't say what you have in mind. The formants, the consonants are crucial to text intelligibility, so they need to be in place and correctly produced in both articulatorily and acoustically. Formants contribute to personal voice timbre. I will expand to that. They are actually like anonymous alcoholics. So they gain in strength as they come close to each other. I will now demonstrate this. I could do this by varying my second formant. Then I should put in the microphone here again, but vary the second formant from a high to a low frequency, and then you will see that the higher, let me make a sound first. Ba, okay, so. Yes, so look at the higher formant here. This is the first, this is the second, this is the third. But now I will move the second formant back and forth, and then you will see that the level of the third formant will be high when the second formant comes close to it, because formants gain in strength as they come close to each other. So let me see. I could then put this here perhaps. Somewhere, and see if this works. Nej, det var mycket dåligt. So this is a demonstration. It can be more striking sometimes that that when formants come close to each other, they gain in strength. This is now possible to demonstrate by the synthesizer, and I should then have the spectrum display showing the spectrum of the synthesizer. So, and then this there, and then this there, and a bit there, and then so. Yes, God silent, yes. Okay. A bit louder, perhaps. Now I will move the fourth formant, which is sitting up here, to the neighborhood of the second formant by means of lowering it. Something like this. And then the fifth formant also. So now you see you have quite a peak here at this frequency. And I could also lower the center frequency of this peak. to 200 hertz. And if we add a little more vibrato, and okay, so I think I could ask for your agreement that this was a great change of the personal voice timbre. It sounded more like a singer, and the fact is that singers are experts in clustering the third, fourth, and fifth formant frequencies, so they generate, as Bob Sataloff was saying, a formant cluster. The singer's formant cluster arises as a consequence that you move the third, fourth, and fifth formant together. They are like anonymous alcoholics, so they gain in strength by coming closer. Okay, let me show you an example of how important this is by first playing noise corresponding to an loud orchestral accompaniment, and then a singer's singing a phrase without a singer's formant cluster, and then with the singer's formant cluster. And third, the examples 1 and 2 together. Here's the sound first. And here's the singer's formant cluster without. And with. And with. And without. And with. And now with the noise. So you cut through the orchestra more efficiently if you have a singer's formant cluster. The two lowest source spectrum partials are called the fundamental. It's called the fundamental, the lowest source spectrum partial, and it carries the pitch perceived. In speech, is it generally lower than the first formant frequency, but composers do what they feel like, and sometimes they place fundamental higher than it should be according to speech precision. Now you remember this formant chart, and if we express the first formant frequency in terms of musical notation, you see that baritones go up to this frequency, about 330 hertz, and then tenors up to 500 hertz, and altos to 700, soprano very high. So then it occurs the possibility that the first formant frequency is below then the fundamental frequency, and that is something that is not nice. You won't get paid for that. So because you can't be heard. So what we have to do there is to modify the formant frequency by modifying your vocal tract shape, and that will give you a possibility to get heard. Okay, so the conclusions are that vocal tract resonances are called formants. They are controlled by vocal tract shape, namely articulation, and the two first formants determine the vowel quality. The higher formants are responsible for consonant production, and the higher formants are also relevant to the personal voice quality. That was it. And now Rahul will take over.
This will advance it. Okay.
All right, everybody, let's talk about the last topic. And we start with a demo. Everybody hold your hands out in front. Bring up to your head. Now move them closer. Those are your ears. I had to do this. I didn't need it, but with so many demos in the last two talks, I had something to do. Okay, so we're going to talk about how you hear voice and how we make sense out of it. That's the last topic for today. And what we mean by perception is the process of making sense out of sounds. It involves a lot of different kinds of decision making. At the simplest level, it might be just detecting a sound. Is it there or not there? And then you go into more and more complex decisions like making discrimination judgments. Is one different than the other? Or identifying it, did a person say a pa or a ba? Or doing some sort of a scaling measurement, how much of one thing is present or another. And it all basically starts with the ear. So the ear has different parts to it. The outside part that you see and the tube here is the outer ear. There's a middle ear part which has a few tiny little bones, the smallest bones in the body. An inner ear which has two parts. The snail-like part is the cochlea that's responsible for the hearing component. And these three tubes over here take care of the balance. I know most people don't even realize that ears take care of balance too, but they do. And then out of those is a neuron, is a nerve, the auditory nerve, the eighth cranial nerve, that goes up through several pathways into the higher brainstem, through the brainstem into the Herschel's gyrus that Dr. Ludlow showed us earlier. Now, each of these parts does different things to the sound signal as the sound travels through it. The outer ear is a tube closed at one end with the eardrum open at the other. Incidentally, it's about the same shape and size as the epilaryngeal tube. And just like the epilaryngeal tube has a resonance associated with it, this tube also has a resonance associated with it. So the resonance will enhance or let certain frequencies go through it much better, much more efficiently than other frequencies. So the outer ear and the middle ear together give us a big transfer function like this. By transfer function, I mean what's the output if you give a whole bunch of frequencies as input. So if I give every frequency from about 100 hertz to about 10,000 hertz at the same power, at the same intensity, the ones right around 1,000, 1,500 to about 4,000 hertz seem to go through it most efficiently and are transmitted most effectively because that's the frequency that's closest to the resonant frequency of the outer and middle ear. What that also means is those are the frequencies where you're most susceptible to hearing loss. So if you're listening to music at a very loud intensity, or listen to it if you're playing in an orchestra and you've got the trumpet behind you, or for some reason you decide to take a nail gun up to your roof and change roof tiles, the first effect that you see is right around 4,000 hertz because that's where the most energy, acoustic energy, is going through your ear. The inner ear is this cochlea. If I cut this through and the snail-like part and stretch it out, you get a membrane like this. It's about 32 millimeters in length. It's actually, there's a thin membrane in the middle with two tubes through which sound can travel. Now, this membrane has a very unique physical property. It's got different thickness and different width along its length. So this part is the basal part. It's right here by at the base of that snail-like structure, and this part is right at the apex on the top. And what happens is, as this is exposed to sound, this membrane in between is set into motion. But because its physical properties are different along the length, different frequencies will excite different parts of the membrane. So for a high frequency sound, the maximum amplitude, the maximum vibration is done right around here towards the basal side of the cochlea. And for a low frequency sound, that highest peak goes deeper and deeper in. So what the ear really does is it sort of behaves like a frequency analyzer. Whenever you hear any sounds, it's got a whole bunch of frequencies in it. And what it is doing is a very basic level of separation. And at each point here correspond to different lengths of the membrane. You have different neurons. And so depending upon which neuron is vibrating, you sort of interpret the different frequency components in the sound in there. So what it's really doing is essentially acting like a whole bunch of filters. So if I take the basilar membrane, stretch it out, on one end it is acting like a filter that only reacts to or only responds to high frequency sounds, and on the apical end, on the top of it, it reacts to only the low frequency sounds. And so a lot of times it's modeled, it's simulated by a series of filters. And of course, filters, they're not placed side by side. This is a real analog system, so it can overlap a bit and help resolve different frequency components. Now, this here, it shows that you have a specific response for a specific frequency, but it's not all explained entirely by the movement of the basilar membrane alone. Instead, the cochlea has a much more complex mechanism which not only uses this but actually enhances how sensitive it is to different frequencies. So there's several active mechanisms. There are cells that will actually enhance or inhibit certain kinds of movements, and that helps us get very, very sharp or very, very fine resolution in frequency. Once this is analyzed by the cochlea, the signal then goes to the eighth nerve, and the eighth nerve has a compressive function. And by compressive, what I mean is for a given big range of input sounds, you get a smaller range of output sounds. And why that is critical is because it allows us to take a very, very wide range of acoustic energy in the environment and still have one organ which can react to the whole thing. So you can have a wide range of acoustic powers that are still audible. And if you want to get some perspective of it, the smallest sound that you hear leads to such a small movement in the basilar membrane. It's about the diameter of a hydrogen atom. And the largest sound that your ear is sensitive to is about 1 trillion times bigger than that diameter of movement. So it's a very, very, very sensitive organ, and it does, in the best case situation, in normal hearing anyway, it does just wonderful translation of the acoustic signal. Now that leads to a whole bunch of different things that we perceive. And when we talk about sounds being perceived, there are three big perceptual attributes we talk about. One is loudness, one is pitch, one is quality. For speech and song, we also are interested in the vowel identity itself. Dr. Sundberg just demonstrated that. And a lot of times, what becomes critical in speech and in music is not just these things by themselves, but how they change over time. So pitch changes over time, and that's used to help us signal a lot of things. In music, you convey certain musical attributes. In speech, intonation pattern will tell you emotions in speech, for example. So all of those things are not just a single pitch, but how pitch is changing over time. That becomes really critical. Let's look at each one one by one. Loudness is that attribute of sensation. This is a definition, a formal definition. It's that attribute of sensation in terms of which you scale sounds from quiet to loud. It is really related to the total energy, the total power or the total intensity of the sound, such that the more intensity that you have, the louder it sounds to us. But the word intensity and loudness do not mean the same thing. Intensity is a physical attribute. It's what you can measure, the sound pressure. And loudness is what it elicits. It's a psychological, it's a perceptual effect of intensity. And the reason they are different is very important because they really mean somewhat different things. For example, if you take a single sound and gradually increase its intensity, the acoustic power it is generating, and then ask people to tell you how loud it sounds, you generally get a curve like this. What happens is, at some level, your ears are not sensitive to it at all. As soon as you can just detect it, let's say it's right about here, and then you gradually increase the intensity. As the intensity increases, the loudness increases very, very rapidly. There's a very quick increase in what you perceive. The loudness, the change in loudness for a very small change in intensity. At some mid-levels, somewhere around here, it becomes relatively linear. That means for equal change in intensity, you get a relatively equal change in loudness. And at very high intensities, it becomes compressive. That means you can have a very big change in intensity for a very small change in loudness. So when you measure intensity, you're measuring along this axis. When you say loudness, you're measuring along a different axis. There are different units for loudness than there are for intensity. Intensity, for example, typically measured in decibels, and the unit for loudness, a commonly used one, is tones. It also varies with frequency. Here's the middle ear and outer ear transfer function again. Obviously, if I give the same intensity sound, a sound at around 4,000 hertz or a 3,000 hertz will sound louder than one at 100 hertz, and that's primarily determined by the fact that the outer and middle ears can pass these frequencies much more efficiently, whereas frequencies above and below that range get absorbed and do not go into the inner ear. Loudness growth is, what that means is, how does loudness change as you change intensity? That function varies with frequency as well. So for example, this curve is called the equal loudness contour, and each line is saying or telling us what is generally perceived to be of equal loudness. For example, on this axis, here's 1K, 1,000 hertz. A 1,000 hertz tone, let's say on this line right here where the cursor is approximately perceived as loud as a 40 dB 1 kilohertz tone. But I lost my mouse. But this loudness is the same as that for a 100 hertz tone, which is almost 70 decibels. So you need a much greater power to elicit the same loudness. But the interesting thing is, as you increase the intensity, for example, if I just increase the intensity from 40 dB to 50 dB right about here, there's a fairly big change in loudness. But if I change the same loudness for a 100 hertz tone, I need a very small change in intensity. So the growth of loudness varies by frequency, and this has a lot of perceptual relevance. So suppose you've built an amplifier, you've got a garage band and you've got an amplifier, and what you do is you decide to change the intensity in your recording or in your playback. If you increase the intensity, so all frequencies go up by the same level, by the same amount, you will actually change the sound quality, because these curves have altered the balance of the low to high intensity. Now, fortunately, if you go buy a good amplifier, they've sort of reverse engineered this and built it into the volume control, so you don't see it very often. But if you buy some regular amplifier and do these kind of tricks, you see a very distinct change in quality just because you're changing the intensity of the signals. In speech and in music, the intensity, the loudness is largely determined by the low harmonics. And that's because the low harmonics always have the greatest power. But they're also affected by the slope. And in all the demos that you saw with Dr. Sundberg, as you change, for example, as you bring the form and clustering, you alter the spectral slope, and that affects the changes in timbre. So I have two sounds here. Let's see if I play them out. They are natural samples, different speakers, and what I've done is I've artificially scaled them so they have the same acoustic power. But as you listen to them, pay attention to the loudness, and what you see is, even though they have equal dB SPL, they will sound different. They will sound to have different loudness. Okay, now sometimes these speakers and the music system here does funky tricks, so I'm not sure if it's accurate, but you should generally get the idea. The second aspect is pitch. The definition is it's that attribute of sensation in which sounds can be ordered from low to high. So you have signals or sounds with low pitch and high pitch. You don't really perceive them as less pitch and more pitch, but you perceive them as low and high. They are generally related to the frequency of a signal. Speech and most other natural signals are complex sounds. And in complex sounds, it is largely related to the fundamental frequency, the lowest component of a harmonic series. But just like with intensity and loudness, the two things, the frequency and pitch, mean slightly different things. Frequency is some physical attribute of a signal. Pitch is what it does to you psychologically, what you hear about it. That's what it's called. In general, of course, the higher the frequency or the higher the fundamental frequency, the higher is the pitch. But the relationship is not a linear one. That means if I increase the frequency and measure the pitch, you don't get points on a straight line. You get them on something which is not straight. Here's what a typical relationship between frequency and pitch for a pure tone sounds. Pitch here is measured in units called mel, short for melody, because pitch really helps you determine melody in music or in speech. There are complex interactions between pitch and loudness, for example, and a whole variety of other attributes of the signal, of the acoustic signal itself. For example, experiments show that if you take single pure tones and of a constant frequency, don't change its frequency, but change its acoustic power. So you're affecting its loudness. And then ask people, what's the pitch that you hear? You actually shift the pitch because you change the intensity. In general, for signals around 1000 hertz, 1K, there's not much of a change as you increase the loudness of the signal. For anything below 1K, you drop the pitch a little bit for constant frequency. And for anything above 1000 hertz, you get an increase in pitch with an increase in loudness. This relationship generally holds true for complex signals as well, including speech. The trends are not as big, but there is a small lowering of perceived pitch as you change loudness. Complex signals have many different components, different harmonics. If you remember all the demos you just saw, each vowel, for example, has many, many different peaks. Those are different harmonics of a signal. But you don't hear different pitches. For the most part, you hear one pitch for each individual complex harmonic series. And that pitch is related to the base frequency, the lowest frequency, or the fundamental, or it's also related to the separation between harmonics. They happen to be mathematically the same things. And you can get some interesting phenomena because of that. For example, if I take a signal like this has several different harmonics. There's 1, 2, 3, 4, and each one is a multiple of the other. Or if I take the same signal and artificially filter out the lowest one, so my signal looks like that, and now I play both of those to you, you will actually hear the same pitch. And here is the signal. Listen to one after the other. The first one comes first, and then this one follows right after that. Pay attention to the pitch. There are some changes in timbre, but listen to the pitch. And generally, these two sound exactly the same, to have the same pitch. And that's because the way the ear analyzes it, it's not just looking at the lowest frequency, but it's looking at the separation between individual components. In fact, when you speak on the telephone, for example, most of the times the lowest fundamental component is not even transmitted through the vocoder, through the mobile phone network, for instance, but you almost never have trouble hearing the pitch of the speaker. In general, we say that the pitch of a complex signal is related to its fundamental frequency. But if you do very controlled experiments, there are slight deviations from that general rule. In fact, what you see is for complex harmonic signals, the pitch is slightly lower than its lowest harmonic, than its fundamental frequency. So if I have a complex signal with a fundamental frequency of 100 hertz, its pitch is perceived to be a little bit below that of a 100 hertz pure tone. And that figure sort of explains what the relationship is. So for a signal of about 500 hertz, the perceived pitch of this complex signal is about 1% lower than the pitch of a 500 hertz pure tone. That relationship holds up to about 1000 hertz, and above that, that discrepancy is no longer there. So the pitch of a complex signal like speech, for example, tends to be slightly below the corresponding pure tone frequency, just by a few percentage points. Variability in pitch, like I mentioned earlier, is very, very critical. It's important for a lot of information we get from speech, and that variability is fairly well captured in the auditory system. The very slow changes help us judge intonation or melody. You can hear the pitch changes, you can track it, you can do experiments where you ask listeners to vary the pitch of a tone which almost match that of a person talking or singing. At somewhat medium rates, about 4 to 6 hertz, maybe up to 10 hertz, you hear vibrato. You don't hear necessarily a change in the overall pitch. When somebody is singing, the vibrato provides it a certain quality without making a massive change in the pitch itself. And at very high rates, the pitch variations are no longer resolved in the auditory system. Instead, they add to the overall timbre of the signal without affecting the overall pitch. A related concept is pitch strength. What you think of is, let's say you have two musical instruments, let's say a flute and a violin or another stringed instrument. Now you play the same note on both of these instruments, and what you hear is one of them has a very distinct, a very salient pitch sensation, usually the stringed instrument, relative to a wind instrument like flute. And what the difference there is called pitch strength. It's really talking about how much or how strong is the sensation of pitch. I have two examples here. One is a pure tone, and another is a noise which is centered around the same frequency. It's a narrowband noise. And I'll play those to you right now, one after the other. And again, the point to notice here is they both elicit approximately the same pitch. But in one, the pitch is really distinct. It's very pitchy, for lack of a better word. The other one is not very pitchy and seems a little noisy, but with the same pitch. Okay, so you get the same general pitch sensation, but one has a strong pitch and the other one doesn't have a strong pitch, and that difference is called pitch strength. And you can actually measure it in subjective experiments. There are also algorithms and models to predict that. And this is something that has not really been studied much in speech and music until about a year or two ago. And then what we are starting to notice now is that pitch strength seems to play a very important role in perception of voice quality. Which brings us to quality. Is that sensation, or that attribute of sensation, that distinguishes two sounds of equal pitch and equal loudness, which means anything that is not pitch and not loudness must be quality. It includes everything which is related to the shape, the spectrum of it, or differences in its temporal attributes, temporal structure. There are many, many, many different ways to define it and describe it, and depending on what kind of population you deal with, you're dealing with a different classification system. For musical, for singing styles, for example, you have a whole bunch of classification terms for quality. People in the clinic use a different bunch of terms for voice quality. There are some which seem to be used more often than others, and there are some empirical basis to come up with these three terms. And instead of defining them, I'll just play you a series of samples. One, the first series that varies on a dimension that goes from low to high breathy. And these are basically signals where these are all coming from speakers where there is some sort of a pathology in the larynx. So it's not affecting the vocal tract very much. It's largely laryngeal configuration. So here are about 3, maybe 4 speakers. And what you generally notice is that the amount of noise seems to increase as you go from low breathy to high breathy. And if you just remember my example on pitch strength, you will notice that some of these have higher pitch strength than others. So I'll play it again. Okay, so that's the continuum of breathy signals. They seem to be varying largely in terms of spectral slope and of the harmonics, as well as the amount of aspiration noise in the signals. Rough voices are voices which seem to have something wrong with their temporal structure. So they don't have the same smooth envelope, so to speak. They seem to vary over time. Okay, and now again, these are natural voices, so they sort of co-vary in multiple dimensions of voice quality. But the point I want to highlight is that voices judged to be less rough tend to have fairly smooth characteristics, and the others obviously are rough. Strain seems to be more related to the perception of effort, and I'll play these out as well. Okay, so they generally lead to dimensions where you think that their vocal fold adduction is really tight and the person's having to put in a lot of effort into producing phonation. So those are the three major dimensions for dysphonic voice quality when the pathology is largely in the vocal folds. You could also have temporal changes or voice quality changes when the problem or when there is some difference in the vocal tract configuration. And there are two major subtypes that there seems to be some consensus about. There's the yawn configuration, where the vocal tract is more open towards the epilarynx and closed towards the front, and the twang, which is the opposite. They are tighter at the epilarynx and wider towards the lips. And I have synthetic samples of these to listen to. So same vowel, but depending on the overall vocal tract configuration, you get a slightly different quality. All right, there are different ways to capture quality, and what you see often are measures reported from acoustic signals, EGG signals, or airflow signals. Things you've heard about, jitter and shimmer and signal-to-noise ratio, APQ, PPQ. There are probably close to 100 different variables or measurements that have been reported in the literature, supposedly to reflect changes in quality. Unfortunately, none of them really have worked very successfully in defining quality. They tend to have poor sensitivity and specificity. They seem to vary as voices become different from normal, but there's no real basis to say what changes happen when jitter changes by X or what changes happen when pitch perturbation quotient goes to Y. And the reason is most of these signals or most of these measurements are really just descriptors of the acoustic signal or the EGG or the airflow waveform. They are not really paying attention to what it is in the signal that makes you feel that a voice is breathy or rough or strained, or if it's open vocal tract or closed vocal tract, whatever it might be. So this is what the voice literature seems to have done for many, many years, but we are moving away from it bit by bit by bit, and there's a lot of new data out there that is coming up with much better ways to capture quality. One of the things very commonly used in speech pathology is measures like dysphonia severity index, and what these are supposedly different or a index to capture changes in voice quality. But if you look at the formula for calculating DSI, it usually uses some weighting of the maximum phonation time. That's the highest fundamental frequency a person can produce, the lowest intensity a person can produce, jitter percent, and the constant. And what should be obvious here is none of these are really measures of quality per se. So what these measures do, what indices like DSI do, are they give you gross correlate of quality, and they have some utility in the clinic, but they are not really direct measures of quality per se. What's being done now, what the research that's happening now, there are two big things that I'm aware of. Jody Kryman and her colleagues are using a multidimensional or multiparametric matching approach. So what they do is have a custom designed speech synthesizer where you're allowed to manipulate different parameters of a speech synthesizer until you get a sound that matches your patient's voice, for example, whatever voice you're trying to measure exactly. When you reach that point, all 4 or 5 free parameters in that synthesizer essentially give you a metric for what the quality might be like. So that's a multiparametric approach that's being followed. We've taken a slightly different approach to do that, and what we've done is essentially taken a voice signal, determined through very controlled matching experiments, some way to quantify what a listener hears of that voice, of that stimulus in terms of quality. So we have a very fine-grained, tightly controlled estimate of each vowel's quality. And then what we do is sort of take the same signal, run it through a computer simulation of how the signal is analyzed as it travels through the outer ear, middle ear, inner ear, and sometimes beyond, depending on what we are looking at. And using those representations, try and predict the same sort of judgments that our listeners do in controlled perceptual experiments. So by doing these series of experiments, we are trying to come up with a systematic way of getting an actual metric of voice quality. It's not just a representation or a measurement of the acoustic signal, but really trying to figure out what attribute of that signal is actually changing the quality of the voice. So in our earliest work, we modeled voice quality as something called partial loudness. And to illustrate that, let me just show you this. So here I have a pure tone, and I'll play it out to you. It sounds like a tone. And now here I have the same tone, but now I'm presenting it with some background noise to it. Yeah. All right, so here's the same tone with some noise in it. It's still pretty loud, but pay attention to the loudness. It's the same tone with equal power. I'll play them one after the other, and your job is to see which tone sounds louder. Here's the one without noise. Which is louder? Not the total signal, just the tone alone. If you listen to just the loudness of the tone, this one sounds louder than this one, even though they have the same dB SPL. And what happens is that, in general, the loudness, the perceived loudness, is a difference between the peak here and the average noise level here, and that's called partial loudness. So what's happening in breathy voices, or so we thought, was that there is some noise due to aspiration, due to leakage at the glottis, which is masking the harmonic signals, and so it's affecting the partial loudness of the harmonic signals. So we use that as a metric for breathiness, and what we find was you take the vowel, a person who's saying ah with a lot of noise in it, separate the noise out of that signal, and then use this noise to mask the harmonic energy, and you compute some partial loudness measurements. And turns out, in a series of experiments, I'm going to go a little quick here, I'm running out of time, we find that the relationship between perceptual judgments of breathiness and partial loudness were pretty well correlated. They were not linear. Remember, it's not a straight line. They were non-linear, but they were fairly well correlated. So what we can do is sort of fit a mathematical equation that predicts that relationship. It looks like this, a reasonably close approximation, and then take that equation to test whether we can predict breathiness for new voices which are not used in this experiment. And our data kind of look like that. The red ones for synthetic voices, blue ones for natural voices. And we get a pretty good prediction, particularly for the synthetic ones. For the natural ones, they look good for moderate to severe voices. It sort of underpredicts it for the low ones, and we suspected that it's because for natural voices, the algorithms we used to separate the noise component from the harmonics started to fail, and so we were not doing very well. In the newer version of this work, we've replaced this partial loudness measure with pitch strength measure, and it looks like it's going to be a much better fit than this one. But hopefully by this time next year, we'll have that data ready to talk about. For roughness, the general theory is that it's related to this amplitude modulation. So if you have a patient go ah, their voice seems to have all kinds of amplitude modulations. And some of them are because of instability in the vocal folds. People just can't control their intensity very well. But some of them are actually probably related to the fundamental frequency. As the fundamental frequency changes, its harmonics change. And as the harmonics change and they move in and out of those formant peaks, you get small but repeated changes in intensity. But the assumption is, based on some theory, is that some of these amplitude modulations, not all of them, actually contribute to the perception of roughness. If I take a sinusoidal signal and then artificially modulate it, but if I keep the modulation really, really slow, that means the amplitude is changing very gradually, you actually hear it waxing and waning in loudness. You hear some part which is softer than the other. As you make that rate of change a little bit faster, it starts to sound rough. And then if you make it really fast, you don't hear roughness at all because those modulations are now too small or too quick for the ear to resolve it. And so it has a whole different effect on quality. So that was the general idea. We just take those waveforms, compute its modulation function, and then do a FFT or identify the frequencies at which the modulation occurs, and then weigh those frequencies. Some frequencies have a greater impact, some modulation frequencies have a greater impact on roughness than others. What those frequencies is still, we are still doing experiments to determine that. But once we know exactly the factors that guide that, we should be able to come up with a very good estimate of roughness. We've done some pilot work, and the relationship looks fairly tight. Again, it's nonlinear, but it accounts for almost 80% of the variance in perceptual data, so it looks very promising. For strain, it's still hypothetical. We haven't done as much work as I'd like to yet, but the idea is that, or the thinking goes that it really relates to the alteration of spectral balance on the auditory domain. So if we take the loudness model, determine how much excitation is caused at different parts of that cochlear basilar membrane, and then compute some metric of the balance, so you can measure things like the mean of the energy or the standard deviation, skewness or kurtosis, that might correspond to strain, but we don't have that data just yet. I'll skip this part. Dr. Sundberg has mentioned this already. A quick note on rhythm. Rhythm's really important in music as well as in speech. And what it really relates to is the subjective or the perception of intervals in speech or in music. And when does the signal go from high loud to low loudness and so on and so forth? Not intensity, but really loudness. There are a bunch of factors that affect what rhythm we perceive, including the notes themselves. So if you have a set of notes which have a very sharp attack time, very rapid rise and rapid fall, and they are separated by equal intervals, the perception of subjective duration between them is actually a function of how quickly they rise and fall. So for example, here is a set of tone bursts essentially, and you can see there is a tone burst. It's on for a while, off for a while, on again, off again. It's on for a longer time, then off for a longer time. And if you ask people to judge how long the gap is between these intervals, it's actually not exactly the same as the duration of the signal. That's represented by these black and white lines. So black indicates when they think the signal is on, white is where they think the signal is off. And notice there's a slight discrepancy between the two, and that discrepancy is related to certain acoustic characteristic of the signal. So rhythm is related to subjective duration, and subjective duration is slightly different from physical duration. And again, it's a complex relationship between the acoustic characteristic of the signal and what we perceive it as. So, in summary, perception results from complex interactions of lots and lots of different acoustic cues, and sometimes they are easier to understand if you try and identify how these cues are represented in the auditory system. Major components are pitch, loudness, and quality. Pitch is not the same as frequency or fundamental frequency. Loudness is slightly different from intensity or power, and quality is not the same as jitter, shimmer, and all of these other measures that we use. So as you go through the rest of the meeting, pay attention to these things, and if you're about to present, Make sure you get your terminology right. Pitch is not the same as frequency. Loudness and intensity are different things. Quality is different from all the other things that we measure. That ends the presentation. Thank you.
At this time, we're going to have Q&A. Do we have a
Oh, this one.
Christy will be coming up, Rahul down, and we're already here.
Yeah.
So if you would, please, if you have any, if you have the energy to ask questions, Mara.
Yes, got it. Good. Rahul, I have two questions for you. You taught us that when we move intensity without changing anything, there is a change in vocal quality. Okay? Towards what direction? Strain, rough, breathing?
Well, that's hard to answer. I don't think we know very well what causes strain, but my guess is it will not be. Well, it could be slightly more strain probably because the higher frequencies may gain more loudness than the low frequencies would.
Okay, that was.
But it's more complex than that. It really depends on where you start from and where you end. Because if you are already started at pretty high level, 70 or 80 dB, those curves are pretty flat on top. But if you're down at 40 dB, you've got a big difference between the low and high frequencies.
May I do a second question? Okay, good. When you showed the vocal qualities, you said there are three main types, the strain, breathy, and rough, and then those are vocal fold level, and then you skip to vocal tract, and you showed yawn and twang. But actually, do you consider yawn a deviated vocal quality? Because all others are deviated.
No, I don't. I was just saying if you break it down by vocal tract configuration and laryngeal configuration, those are the two big ones that show up. There are certainly other terms that are used, and none of those really apply very well to the singing voice. That's a whole different classification system.
Thank
So
you.
no, it's not disordered necessarily.
Yeah.
Hello, yes, it works. Actually, one more for Rahul. Rahul, you have shown the transfer function of the outer and middle ear, and there is a clear prominence of 3000 hertz. But when you show the famous equal loudness curves, there is actually no prominence at the loud voice. So what happens? Where does the compensation happen?
Well, one's physical. The transfer function is pure intensity. The other is loudness. And so, I mean, I guess we are wired that way, that we are inherently more sensitive to the high frequencies. One is the equal loudness contours is all perceptual data. And the transfer function is actually just the physical intensities.
Okay, but is it in the brain? Is it in the basal membrane, cochlea? Where?
Well, that's hard to.
Okay.
I don't have the answer for it.
I accept that
somebody
answer.
Else
Thank
might
you.
have it.
How does that relate then to injuries, loss starting around 4,000 for loud sounds? Hearing loss at, like the notches at 4,000.
Yeah, well, that's purely, again, all physics, because if you are exposed to all different frequencies at equal level, the 4,000 hertz is what's going the most into the ear, and so it's purely, largely physics anyway.
You don't have to take a number. No, come to the mic.
This question is for Johan. You talked about the singer's formant, and that the singer's formant was formed by the convergence of the higher formants. Is the singer formant also, can it also be formed by suppression of all but, say, the third formant, all the higher formants except the third, and then somehow boosting the third? Are those synonymous?
Well, the fourth and the fifth boost the third by being close to the third. So that is the...
And there's no other way to boost the third, no other vocal tract configuration that would boost the third and suppress the higher formants?
No, well, then we come up into the nasal cavity. If you could do some tricks with adding nasal resonator to change the balance in the spectrum that is being irradiated. That may be. By the way, I have started to call that spectrum peak the singer's formant cluster to distinguish it from what is perceived as the vocal ring, which means, I think, just that it is a good amplitude of the higher formants in the singing voice, which is found also in female singers. But singer's formant cluster is a male characteristics.
Yeah, the reason I ask, it reminds me of what some other animals like the bat will do. The bat will change its vocal tract to suppress higher harmonics.
Please repeat that.
Animals such as the bat will suppress various parts of its vocal tract, higher harmonics, to enhance the detection of the narrower bandwidth signal. And that was one of the reasons, one of the other speakers, I believe, mentioned that the singer's formant is used to cut through, it was used to cut through the noise of the orchestra.
Yeah.
It reminded me of that.
Okay, thank you.
Thank you very much for the information. I appreciate that. I snuck up on you. Yeah, I'm sneaky like that. First a comment and then a question, I guess, for the group at large. I found it helpful in a lot of my research and a lot of my teaching centers around source properties versus filter properties and interactions between the two and so on and so forth. With students and with singers, whether they're a singing student or speech pathology students, I find it very useful to clearly distinguish between what is a voice quality and what is a resonance or a vocal tract. I call it a vocal tract quality. So we would never want to say that yawn is a voice quality. I found that that's helpful to the student. And then the question that I had, this is just a hypothesis that I'm wondering if it has been researched or not. For the pitch modulated auditory feedback that is presented to speakers or to singers, I'm curious about if anyone has thought of experimenting in the realm of singers, highly trained singers versus non-singers, in that I believe that perhaps highly trained singers, because of the sensory feedback, mechanical receptor, strain and stress feedback, regardless of what they're hearing, I'm thinking that they might be a little less likely to change as much in amplitude, and not amplitude, but the actual change of pitch that they're producing, the actual total amount of change. Anybody ever thought of that? Am I making any sense at all? So they're not just going to depend as much on the auditory feedback, they will have a more highly sensitive and trained sensory feedback? Yeah, kinesthetic. Yeah, kinesthetic.
I don't know if people have studied that. It's pretty difficult to study. People have done lidocaine block of the mucosa, and it doesn't alter the voice that much. In fact, but they haven't looked at highly trained singers.
That's what I'm thinking.
As far as I know.
I would think it should be pretty straightforward. Thanks.
Well, let me also add that voice and resonance is probably related to what is also called phonation, which is the operation of the voice source, the vocal fold sound generator, and resonance is the vocal tract and the formant frequencies. And they, in yawn, both are engaged because you lower the larynx and then you lengthen the vocal tract, so the formants go down. And then you tend to abduct the vocal fold, so you get an effect on the phonation quality also. So it may be, in reality, they are tied together, as we all know.
There was information, Christy, when you mentioned about this cortical bulbar tract, that it only exists in humans. I found that to be very interesting because I think much more an electric being also that's not really getting talked about, not just chemical. And also the two nerve sides of the brain that go all the way over. And the picture, if it was facing us, it was all going over to the left side or to the right side. It was the right side on the screen, but was that the right side?
The diagrams were showing contralateral projection. Usually in the limbs, you have the right side, the right hemisphere controlling the left side of the body and the left hemisphere controlling the right side of the body. You don't get bilateral control in one hemisphere. The difference is for the larynx is each hemisphere has bilateral control for the larynx.
Well, it was I'm talking about the design where the picture where they were both going to one side, the
yes.
nerves.
Yeah.
Now, and because
but you would have exactly the same thing for the other side of both sides going.
I was just wondering, when the vocal cords open, and they open from the left to the right, if it was going to the point of that opening, if those nerves had to do with that point.
Well, the nerves go to the muscles,
yes.
and the nerves are the motor neurons
yes.
going to the muscles. The input to the motor neurons is from the cortical bulbar tract, and you have a cortical bulbar projection both from the ipsilateral hemisphere as well as from the contralateral hemisphere. I was just showing the example if you're looking at one muscle, but if you did the same thing for a muscle on the other side, you would find the reverse.
All right, it was more the muscle, not exactly right to the vocal cord itself area. I mean, to
the brain sends a tract from the hemisphere down to the brain stem. That's the cortical bulbar tract. It goes, if I have this hemisphere, it will go to this side and to that side of the larynx. It'll go to both sides.
Thank you. And there was a mention earlier about in the description of the vocal folds of the exterior that there were hairs. That caught my attention because in the ear, I'm under the impression that it's millions of microscopic hairs that are sending the electric signals to the brain. So if there is this sort of liquid element, then the electric from the brain is maybe getting picked up on the hairs of the vocal folds. And it just was something that it just...
I think those hairs are the cilia, and they're not necessarily sensory hairs like they are in the ear. They're moving fluids up and down on the mucosa, but they're not sensory connections to the brain.
To Professor Sundberg, I just want to be sure that I got it right. So you call the singer's formant cluster, and this is only for men. And for female, you call it ring.
Yeah, or a spectrum peak, or something else.
And what about for the actors?
For the actors, I think they have the speaker's formant peak, which is about 1,000 or 800 hertz higher than the typical frequency center of the singer's formant cluster that males have. And male rock singers and pop singers and actors and radio announcers all have this. And recently Timo Leino and his colleagues had published an article saying that this was also a formant cluster effect, but it was the fourth and the fifth formant that came together to shape this. And
so for the actors, is a cluster also, but it's fourth and fifth.
Yes, according to Timo Leino and his collaborators. And to generate it, it is of course necessary to have a good voice source that produces partials up in that frequency range.
Yes.
So it won't appear if you have only noise in the voice source about 3 kilohertz.
So, Johan, if you take the soprano voice, I guess maybe anywhere in the range, and it rings, it carries really well. There's some higher frequency as well as maybe the close to the first formant business, but two distinct things. Would you be looking then for a prominent partial that is creating the ring, or how do you now define that ring or higher frequency carrying power?
I think it's related to the energy in the high partials. And the partials that in the soprano range are rather far apart from each other, so they don't really form a cluster of partials. But I'm sure that there are things that go on also above 4 kilohertz that may be important to those quality. On the other hand, the radiation of high frequency from the mouth are very, very directed. It doesn't scatter like the low frequency. So if it carries well in one direction, I wonder how it carries in the adjacent directions. Who knows?
Well, do you think actually the partials, the harmonics are spaced further apart of the higher pitches? Could it be the same phenomenon of the formant clustering, but you just have, you have like a partial one harmonic in the region? So could it be the same?
Yeah, maybe it's not so good to cluster the formants because some pitches won't produce any partial in that cluster. So maybe it's better to separate them and increase the likelihood that at least one partial hits one of these for higher formants. We don't know very much about these things.
Maybe there's, you've talked a lot about the first formant tracking with the fundamental. Maybe there's a higher formant tracking with higher partials.
That would be a hard job. I mean, the higher formants are very sensitive to the fine details of the vocal tract. You need to be very precise. And
I only know fine sopranos.
Okay.
Hello, this is a question for Johan, I believe. Is there a resonant frequency for the trachea? And if so, what effect, if any, does that have on voice production? I'm thinking this might not be a short answer.
When you pronounce an H sound, then you have the tracheal resonances in action. When you phonate, the effect seems to be very small. So the sound down in the trachea changes very little if you change the vowel. So it seems that there is no strong reason, I think, to assume a strong effect of the subglottal resonances on the voice production.
Well, I mean, because the trachea is a airway, basically closed and then open toward the lung, you do have resonances. So depending on the literature, basically around 600 hertz, maybe with females it starts at 700 hertz or so. And so they are there. Yeah, short people. So they are there, and when you are phonating, there is pressure variation below the vocal folds as there is acoustic pressure variation above the vocal folds. And the transglottal pressure, the pressure difference between the sub and supra, then is pressure that difference is always acting to drive the flow as well as to push on the vocal folds. So the subglottal resonances actually can be quite important, especially then in certain discussions of passaggio for singing and things like that.
Hi, I have a question to Dr. Sundberg. When you say a soprano don't have singing form and cluster, are you talking about any specific kind of soprano, lyric soprano, or any kind of soprano?
Any kind of soprano would be my guess. It is difficult to measure form and frequencies in high voices, but there has not been any evidence of a form and cluster. I mean, if you have a fundamental frequency of 700 hertz, that is F5, the partials are 700 hertz apart. And now if you form a cluster of the third, fourth, and fifth formants, say in 700 hertz, in a 700 hertz band, pom, 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 they are 700 hertz apart, the third and the fifth.
Yeah.
Then it will happen that some scale tones don't have any partial at all in that cluster. So the advantage of having a formal cluster at high-pitched singing is very doubtful.
Okay.
I think you will be a better singer without it.
Okay, because we have found some singing from a cluster in spinto sopranos.
Yeah, I stick to my belief that they don't have any clustering of these three formats.
Okay.
Maybe they, as Ron was saying, managed to match a partial with a resonance so that it develops as a strong harmonic in the spectrum, and that may be the efficient way to produce a ring or ping or what you call it.
Okay, thank you.
In your work, do you use like a noise source or glottal fry to figure out where the formants are and then they sing?
I don't know exactly. Do you know, Luis, exactly where is the formant you found in spinto soprano? In which frequency? Yeah, 3,000 or above 3,000.
Yeah. Well, I think this actually, there are the two methods now that people are trying to use: the glottal fry, keep the vocal tract shape, and produce sound that Don Miller and others have been dealing with. That may be a potential to track these formats, these resonances, to see whether or not they're present in some way. And then Joe Wolf and his group also have a noise source that allows you to try to see what the formants are, even though then when phonation is there, the fundamental frequency is high and the spacing is great. So I think we should continue with those kinds of things. Maybe Jan has a concept.
There is a difficulty that you, when you go from vocal fry, from phonation to vocal fry, you change the details in the laryngeal range, and those are crucial to the higher formants. So that's a problem. And then I think that Joe Wolf's method is also a bit shaky when it comes to higher formats. He is very definite about the lower ones, and we have to ask him about that.
Thank you.
One more question for Johan. Johan, there is this placement of the voice in singers where singers should feel some vibrations, and it's very often related, or in the singers literature, it's related to the resonance of the cavities, of the sinuses. The scientific literature and the singers literature is pretty much in contrast. The singers literature says this is important. The science literature says this is not important. Well, maybe we should do some more studies about that. But what is your view of this kind of problem? Well, there is, the essential statement of somebody listening to a person who's got problem with the sinuses. the singers say, yes, we can hear, this is not the voice it should be because there is the problem of the cavities. Do you think it can be heard? And if so, how?
Yeah, what the sinuses do is to eat sound. They eat their five favorite sounds. So they suck out of the sound that is passing them their resonance frequencies. If it may be possible to hear that the partial is missing in the spectrum, but it is generally quite difficult because of critical bands and masking things.
Yeah, but it would eat the tone or the partial only when it's empty. When it's filled, it would not eat it.
If it's swollen and full of water, it won't eat anymore.
Yeah,
it has
so
no appetite.
that should improve the voice then.
Yeah, but and if they close, if the additus is sort of swollen so that it can't communicate, it will stop to resonate. On the other hand, the sound pressure you have in your mouth and the vocal tract is huge. It's 140 decibels and more, so it shakes the entire skull. But I don't think that the skull as a sound radiator is very efficient because the air will go from side to side if you do this. So maybe if you place yourself in a buffle, you could do it. But I think there are open questions with respect to vibrations, skull vibrations, and their role in controlling sound production. I don't know, do you have anything of vibration sensation in the skull as a control signal for phonation in mind? Christy? Okay.
Well, it's been a long day. Thank you so much for being here. We all urge you to take full advantage of your time here. Speak with as many people as you can about all the questions that you have in general and in specific. Make new friends. Have a great week. Come back next year. At the end of each meeting, there's going to be people who have a certain tag, I believe, starting tomorrow, and they are from the Scientific Advisory Board, and they are going to be there to and they will answer questions that you have. That is, you can ask them questions, and we don't know what the answers are going to be. But they're going to be helpful people at the end of every session. So watch for them. They'll have a special tag that says, "Ask me," or something like that. Have a great week. Thank you so much.
I just wanted to say one more thing. Okay, I have to politely, I don't think I disagree with you, but I think we may say the same thing. I know you know.